Okay, thanks everyone for coming. It's great to see the hall filling up. We really appreciate your commitment to the session. It was a fantastic session, by the way, but it's Saturday afternoon, so it's great to see people enthusiastic to learn about hand dermatitis. I'm Alan Irvine. I'm the current president of the International Eczema Council. So we're just going to talk a little bit about the IEC and then we'll set this up and introduce you to your session chairs, and I will let it move on. So I'm Professor of Dermatology, Trinity College Dublin, and Professor of the IEC at the moment, Chairperson of the IEC. Just a couple of housekeeping comments. This is going to be recorded and it will be on our media channels. It'll be on YouTube, it'll be posted on LinkedIn, Twitter, and you can get all of the content for free afterwards. If you have questions about the IEC or today's session, email info@eczemacouncil.org. If you want to join the Eczema Council, if you have any queries, you want to find out about it as an associate or as a councillor, email Alan Stiles. This is the email below. The QR code here will give you the programme guide, and it includes today's agenda and all the speakers. So I'll just leave that for 10 seconds if anybody wants to do that. And then you can follow a lot of the data on your phone. Okay, when I see phones going down, I'll move on. Right, I think you've all got it. Just briefly about the IEC, international is the first word in it, and we're really keen to develop international relations wherever we possibly can with people who are passionate about studying the causes of eczema, atopic dermatitis, about driving forward education, patient care, and improving the lives of people who live with this itchy and uncomfortable and very prevalent condition. Currently we have 32 countries. They're listed here. I won't go through them all individually. When you add it up, we have 145 councillors and associates from 6 regions, 32 countries. And if you know somebody, or if you are somebody from a country that's not represented, or if you're even if you are from a country that's well represented and you're interested in joining, we want to hear from you. Just to break it out in a slightly different data visualization way, North America accounts for 32% of our councillors, originally grown and developed in North America with Amy Paller and Emma Gutman. So you can see how internationally spread it has become since then. Europe is 37%, Asia Pacific, we would like more. We'd like more councillors from Africa and certainly more from the Middle East and South America as well. Councillors are slightly more senior, a little bit more proven accomplishments behind them. Associates are earlier in their career. Please consider applying for either. Recently, we welcomed allergists, so this is relevant for hand dermatitis, obviously, and allergic contact dermatitis and others. So that's now to broaden the family of people who are professionally involved in caring for and researching atopic dermatitis. So we had our first allergists this year. The PhD program will start next year, so we have made the decision to expand access to PhDs. Some would say we should have done it earlier, but it's been taken through all of our necessary processes, and the criteria will be out Q1 2025, and we should be open for applications. So similarly, if you run a lab, if you've got somebody in the lab who you think would like to be involved, who's a PhD rather than an MD, PhD, then please consider this as well. Just to break down our key kind of themes, our mission is to improve patient care by promoting research, education and best practices in treatment for atopic dermatitis in people worldwide, a global mission. A vision is to transform the lives of people with atopic dermatitis. We have an anthem, which is that we're a global community of leaders in atopic dermatitis research, treatment and prevention. And our values that we're patient-centred, innovative, evidence-based, globally inclusive, collaborative and forward-looking. I think you're going to see these qualities on display in this very strong session that is about to start. So just to thank you to our sponsors, some of whom are in the room. We really appreciate that. If you want to be a sponsor or a supporter and you're not, Alan is here. He's always keen to talk to you. If you are, thank you for your generous and ongoing sponsorship that makes these types of things possible. Just briefly what we've done this year, we've been at the Academy, we talked about topicals in the pipeline. We were at RADLA in South America in May, we're at the SID, we're at IACI, ESDR, and this is the final session of 2024. And next year we're going to be in 6 conferences. We're going to be at the Quad AI, talking about the impact of environmental, food and contact allergies, San Diego, alopecia areata, the relationships. There's going to be some patients at that, at the AAD in March. World Congress of Pediatric Dermatology, we're back in South America in April, Buenos Aires. The SID is going to feature a multi-omics session, that's in May. It's also in San Diego. The impact of environmental, food and contact dermatitis is going to be different from the Quad AI, but it's on the same thematic area. It's going to be in Glasgow. And finally, at this conference next year in Paris, France, we're going to talk about atopic dermatitis and CTCL. We have a social media presence. Please follow us, like us, amplify the message. Probably most of our content comes out on LinkedIn and YouTube, but we're also on Facebook and X, formerly Twitter. YouTube has got 130 videos, not counting what you're going to get added up today. So it's a good learning center to promote for anyone who wants to learn about specific aspects, and we're working at making that super tidy and super easy to get. Any questions? Alan Stiles. So I'm going to hand over to the people who are really doing the work today after my introductory remarks. I'm delighted that Robert Bissonnette is with me today. He's chairing this session, co-chairing it with Tova Anger. Anya. Sorry, I'll try and get that right. I'm trying. It's not Anger, it's Anya. Anya. So it's fantastic to have Tova and Robert here, 2 really accomplished people in this space who are going to both speak and guide us through the session. Robert, I think everybody knows, he's a media past president. He's a Canadian dermatologist of great repute and a very well-published clinical investigator. Tova is a professor emerita now. That's a fantastic position to be in, hopefully. More fun and less responsibility, but has a huge career of achievement behind her, and we're really delighted that she's going to bring all those decades of experience and findings and publications on hand dermatitis to this session. So we couldn't be in better hands. And without further ado, I'm going to pass you on to our chairs, and we'll move on. Thank you.
Yeah, thanks to the audience for being here this afternoon, this very late afternoon. It's a very great pleasure for me to open this symposium on chronic hand eczema. And I would like to introduce you to the topic. First, these are my conflicts of interest. And then we'll take some essentials about chronic hand eczema. First, I think we should take it from the perspective of the dermatologist. Some important basics that we should all know about chronic hand eczema. We'll go through that. I know that some of you may have heard it already during the last 2 days, but we'll try to repeat some of it. A chronic hand eczema is an eczema localized to the hands and wrists only. It's not part of a systemic disease. The morphology of hand eczema when it has a flare-up is erythema, infiltration, vesicles, and in the more silent and chronic periods, it's more scaling, fissures, and hyperkeratosis. The chronicity of hand eczema is defined in a way that it lasts for more than 3 months, or that it relapses more than twice every year. So who has chronic hand eczema? If we look at the distribution between men and women, we can see on this slide, which is actually 500 European patients with hand eczema from 10 different centers in Europe. And you can see here that in the younger age group, it's much more prevalent to have hand eczema among women than among men. But when we become older, it's more the same between sexes. And we think we can explain this by more wet work exposure to women. At home, probably we don't know so much about that, but for sure we know that much more women are occupationally involved in wet work situations. So this probably explains this difference. Chronic hand eczema is quite prevalent. The one-year prevalence of hand eczema is about 10%. And it's also a chronic disease, since if we revisit patients after 5 years, we find that more than 70% will still have an active hand eczema at that moment. Twin studies have helped us to study whether it is an inherited disease. And the results show that about 40% of the background for the disease is genetic, while 60% is explained by the environment. And what does this mean? If we compare, for example, to other diseases like psoriasis, like atopic dermatitis, they are much more genetic. That will explain almost 90%, 80 or 90% of the disease. But here we have actually 60% of the background for hand eczema is explained by environmental exposures. And this means that even in this period of time where we are learning about new treatments of hand eczema, we should never forget prevention, because prevention is very important, and we really have a chance here, since 60% is actually explained by the environment. We should be able to do a preventive effort for this disease. I think that Sven will come back to that later, I'm sure about that. We have different subtypes, and I think now we have an agreement that we have some etiological subtypes and we do have some morphological ones. And the etiological subtypes are, of course, the allergic and the irritant contact dermatitis, and also the protein contact dermatitis, which we do not see so often anymore, but it's still quite important. Atopic hand eczema is a big percentage of all cases. The morphological subtypes, the more frequent ones, are the hyperkeratotic hand eczema and the acute recurrent vesicular hand eczema. But be aware that the morphology does not necessarily reflect the etiology. And what does that mean? It means that by looking at the hand eczema, you cannot explain why this hand eczema has started. So we really need to do a full workup on all the patients, and we need to do patch testing to exclude that there is any contact allergies around. Risk factors for development of hand eczema and chronic hand eczema, of course, atopic dermatitis is the most important one. If you have or have had atopic dermatitis, there's an increased risk of about 3 or 4 times as compared to those who have not had that disease. Exposure to irritants, and you are exposed to irritants if you have children less than 4 years old in the home, and if you have no dishwasher. That's also a risk factor for exposure to irritants and thereby for development of hand eczema. Having a contact allergy is also a risk factor for development of hand eczema, and dry and cold weather conditions like those we have in Scandinavia, they are also risk factors for hand eczema. Interestingly, there's also an association to lifestyle, and we know that several very good papers out there now assuring that there is a significant association between severe chronic hand eczema and tobacco smoking. So tobacco smoking should be included in the patient education programs for patients with hand eczema. Also, lack of physical activity and a high body mass index may influence severity in a negative direction, as may also psychological stress, although the evidence for that is a little bit less strong. So this was essentials from the dermatologist perspective, but I think we should also take a look at hand eczema from the patient's perspective. And what does the patient feel about this or think about having hand eczema? They know it's not a deadly disease for sure, but it is a disease that you'll have to live with for many years. May even lead to job change for some patients, and it has a negative influence on quality of life. And when we say that, I think we should also go into some examples, look at what does it actually mean to have a negative, that a disease has a negative influence on quality of life. So I would like to give some examples of from a daily life with patients living with hand eczema and where this situation can be challenging. For example, in the morning, getting dressed may cause pain, and you may even leave some blood stains on your clothes, which is not so nice. And wet work at home will aggravate the chronic hand eczema. It may also cause you pain to have give your children a bath or to do the washing at home. And if you're a person occupied with wet work, then of course you will have a further aggravation of the hand eczema. Touching food is no-go if you have a hand eczema. Preparing breakfast, lunch boxes, or dinner is not a good idea, because if you have a moderate or severe hand eczema, you will be colonized on your hands, on the skin of your hands, with Staph aureus in more than 50% of the cases. So touching food at home, touching food occupationally is a no-go if you have hand eczema. Embarrassment is also part of the disease. If you have hand eczema, you may be embarrassed at work, even if you have an office work where you are not bothered so much by your hand eczema. Embarrassment may be a factor, and of course also in personal life, you can sometimes be embarrassed by these red and scaly things on your hands. Sleeplessness is reported by 40% of patients with hand eczema. They are bothered by the itch during the night. So now I think I have kind of given you perspectives from the dermatologist perspective and also from the patient perspective on giving you the basic things about hand eczema. I'm kind of warmed up to the symposium. And the program today will embrace many different areas. We'll go through biomarkers, we'll talk about the microbiome, contact allergies will be pointed out for us, occupational and non-occupational hand eczema during childhood, which is also a very important area, topical and systemic treatments, and also future options. So with this, I would like to call for our first real speaker today, and that is Dr. and PhD Caroline Olsen. And Caroline is at the moment a postdoc at the University of Copenhagen, and Caroline has a PhD where she has been in New York at Emma Gottman's lab also, and she has a PhD from the University of Copenhagen where she has looked into biomarkers in atopic dermatitis, but during the last years you have only focused on biomarkers and hand eczema. So we're really excited to hear more about that. So.
Well, thank you for that presentation, Tove, and also thank you so much for having me here today. Today I have the pleasure of telling you about biomarkers in chronic hand eczema, and the title is Are Biomarker Helpful for Identification of Hand Eczema Subtypes? And as Tove just told us, subclassification of hand eczema has really been a matter of debate, but now, according to the most recent guidelines from the European Society of Contact Dermatitis, it is recommended that we subclassify hand eczema into these 8 subtypes, with the etiological subtypes and the clinical subtypes. And it's still quite challenging in practice, because we see a lot of patients who show mixed subtypes and also that change morphology and also sometimes subtypes over time. So if we had a set of biomarkers that were able to distinguish between the different types of hand eczema or subtypes of hand eczema, that would really be a valuable clinical tool. But what is an optimal biomarker? First of all, in order for us to use it in the clinical setting, it should be quite easy to measure in a standardized way and also without causing too much harm for the patients. Then it should correlate with disease severity. It should aid in this subclassification by having a high positive predictive value. And the optimal biomarker would also tell us something about the major disease-driving pathways and thereby be able to predict treatment response to different targeted and non-targeted therapies. So there are several studies that have investigated the molecular profile of hand eczema as one entity compared to healthy. And overall, these studies show that we see a similar molecular profile as we know from atopic dermatitis. So we see skin barrier impairment, we see immune activation of both the adaptive and the innate immune system, and then also increased Staph aureus colonization. And then it has also been shown that biomarkers assessed from the dorsal lesions are quite different from the palmar lesions. So we have to take this into consideration when we investigate biomarkers in hand eczema. At present, there are relatively few studies that are investigating directly comparing biomarkers in different subtypes of eczema. And as you see here, a great proportion of these are focusing on differentiating allergic from irritant contact dermatitis. And now we take a closer look at some of these studies. So the majority of these studies uses a patch test setup in which they collect skin samples from patch test lesions, so lesion induced both by contact allergens and skin irritants, and also from non-lesional skin, and then they analyze with different analyzing assays. So based on these studies, the major conclusion is that in allergic contact dermatitis, we see increased expression of markers associated with T-cell activation and T-cell receptor signaling, and also different subtypes, subsets of T-cells. And the profile, or the molecular profile, or immune activation is dependent on the type of contact allergen. So metals are inducing more a Th1, Th17 response, while fragrances are inducing a Th2, Th22 polarized immune activation. Irritant contact dermatitis, on the other hand, we do see some T-cell activation, but to a much lesser extent compared to the allergic lesions. But we do see increased in innate immune markers, and also there are some increased expression of markers related to cell cycle regulation and cellular energy metabolism and cornification. And these are pathways that are promoted by this tissue restoration that are induced by the skin irritants. So overall, this do support what we know about the pathophysiology of these diseases, with allergic contact dermatitis being a T-cell mediated disease and irritant contact dermatitis being caused by damage to the keratinocytes by skin irritants, and thereby promoting of these tissue restoration pathways. In 2 of these studies, they also applied different machine learning models to identify molecular classifiers that were able to differentiate between the different, between allergic and irritant contact dermatitis. And they managed to do so. They did identify several or multiple classifiers that were able to differentiate based on these major differentially expressed genes. But even though this is really a step in the right direction, we also see that the markers that they have identified in these 2 studies are not the same. So this really highlights that we do need more studies in order to find a validated set of markers that can differentiate between allergic and irritant contact dermatitis. There are also several studies that have investigated whether hand eczema patients with atopic dermatitis show a different molecular profile from the hand eczema patients that do not have a history of atopic dermatitis. And in these studies, 2 studies based on RNA sequencing on tape strips and 1 doing O-link profiling of plasma, they do find that overall the molecular signature of hand eczema patients with and without atopic dermatitis is very similar. So you see a shared signature. And in the studies doing RNA-seq and tape stripping, they did find that the non-lesional skin of these patients with atopic or with hand eczema and atopic dermatitis showed an increased expression of inflammatory markers of the non-lesional skin compared to the hand eczema patients that did not have any history of atopic dermatitis. So this suggests that the non-lesional skin might be a way to differentiating between hand eczema patients with and without atopic dermatitis. In the study doing O-link profiling on plasma, they showed that patients with very severe non-atopic hand eczema had an increased expression of Th1-related proteins or increased level compared to healthy. And this was not the case for the hand eczema patients without atopic or with atopic dermatitis. So this may suggest that the Th2 pathway is upregulated in hand eczema patients without atopic dermatitis. But of course, we need more studies to confirm whether this is the case. So at present, there is not a lot of studies that have investigated how the clinical subtypes are influencing the biomarker profile. But in this study by Quade and colleagues, they did include different etiological subtypes and also classified the patient according to the different clinical subtypes. And then they did O-link profiling of plasma. And they did not find any difference between the etiological subtypes, but they did find an increased Th2, Th1 profile of very severe allergic contact dermatitis. But with respect to the clinical subtypes, they did find an increased expression of Th1 and TNF-related markers compared to healthy in the hyperkeratotic hand eczema patients. And also, when they compared the hyperkeratotic hand eczema patients to the other clinical subtype, they did identify two markers, two proteins, that were related to Th1 and TNF signaling, which was increased in the patients with hyperkeratotic hand eczema. So, a little bit more about the clinical subtypes. For the hyperkeratotic hand eczema, based on the few studies that are available, it may remind a little bit more about psoriasis, both with respect to histological features, and also we do see some alterations in the skin barrier, but it is with altered keratin expression, and at least according to one study, that are not decreased expression of filaggrin and other key skin barrier proteins, which is different from the other types of hand eczema. Also for the vesicular hand eczema, we have really few studies, but in one study from Dr. Schüttler's group, they did collect skin biopsies from vesicular hand eczema patients, 10 vesicular hand eczema patients, and did RNA sequencing on these skin biopsies and compared it to healthy. And overall, they did show that the transcriptomic profile of these patients was very similar to what we know from atopic dermatitis. And later on, they did compare it to a skin barrier transcriptomic profile from skin biopsies from atopic dermatitis, and did show that there was an increased interferon signaling, among other things, in the vesicular hand eczema patients. And also, the vesicular hand eczema patients differed by having normal non-lesional skin, which is unlike what we see in atopic hand eczema. So, to sum it all up in a bit simplified table, allergic contact dermatitis is related to T-cell activation and skin barrier impairment, and the subset of T-cell activation is dependent on the type of contact allergen. Irritant contact dermatitis, we do see some T-cell activation, but to a much lesser extent. But we do see increased expression of cytokines produced by the keratinocytes and other innate immune markers. And then we see this increased expression of markers related to epidermal restoration and skin barrier impairment. For the atopic hand eczema, we see the classical atopic dermatitis profile with Th2, Th22 polarized immune activation and skin barrier impairment. And contrary to the other types of hand eczema, they have great abnormalities of the non-lesional skin as well. The hyperkeratotic hand eczema, based on the few studies that are available, shows immune profile with Th1 and TNF signaling, and there is, at least based on one study, no skin barrier impairment as we know it from the other types of hand eczema. But we do see altered expression of keratins and also markers of keratinocyte proliferation. And then there is the vesicular hand eczema, which shows an overlap with atopic dermatitis, but with normal non-lesional skin and also increased interferon signaling compared to atopic dermatitis. So, are biomarkers helpful in identification of hand eczema subtypes? For now, we are not there yet. We do see a lot of markers that are differentially expressed in hand eczema patients compared to healthy, but the majority of these markers are shared between the different subtypes, or some of the subtypes at least. So we really need more studies on chronic hand eczema lesions, also the clinical subtypes, and that is what I'm working on right now, and also what I know a lot of other groups are working on, so we will get there, hopefully. And if we manage to identify this set of biomarkers that can differentiate between the different subtypes of hand eczema, then we would need an easy and standardized way to measuring that in order for us to use it in the clinical setting. So, if we get here, and I know we have been speaking about this for years, so it is quite a hurdle, but then we also be able to guide the therapeutic decision based on the biomarker profile and the molecular profile. And then we may move from this clinical subclassification of hand eczema towards a subclassification that are more based on molecular profile of the patients. So that was all for me.
Thank you so much, Caroline, for this really good and comprehensive talk. We have time for a question, if there are questions. I have one to start up the discussion, and that is, how much does the severity of the eczema mean? Is that even more important than subtype for all these biomarkers, or what do you think?
Well, in my opinion, is that it seems to be that way. So we see with mild hand eczema, we do see much less biomarker profile. So for all these subtypes at present, we have a shared profile in compared to healthy, and the severity is correlated with several of these biomarkers. So I think that severity for now is a major factor and much more important. And also I know with my data that unfortunately is not ready yet, we have to stratify in the different severity groups in order to see if there is a difference between subtypes, and I would also advise others to do the same. So yeah.
Okay.
So I think severity is very important to have that. Yes.
Any additional questions from the audience? I do have one. So any work you're currently doing in terms of biomarkers of clinical response? So biomarkers of severity are interesting, but in terms of clinical response, we know that some of those subtypes are a little bit more difficult to treat.
Yes.
So are you doing any work in that area?
Yes, we are. We are looking at biomarkers before and after treatment with topical corticosteroids. And as you know, the hyperkeratotic hand eczema is not responding that well to topical corticosteroids. So we really have a cohort with patients that are responding quite well, and also a subtype that is not. They're not responding that well. So we will see if we can see anything in the biomarker profile of the patients that are responding well and the patients that are not. We are also going to look into that, or looking into that. But yes, I would be happy to come back and tell you about all the amazing results, hopefully.
Okay, we will really look forward to that, Caroline. Thank you so much.
Thank you.
The next topic is microbiome, and there have been several talks during this congress on microbiome on the skin. And our next speaker, she's really an expert. Line Borg Nørstedt is also from the University of Copenhagen. You have done a PhD on bacteria aspects on hand eczema, and you've also done a lot of microbiome studies, and we are really looking forward to hear some of your results here, and whether it's important or not with the microbiome in relation to hand eczema. Please, Line.
Thank you for that introduction. So, my title is The Microbiome's Impact on Chronic Hand Eczema, to Treat or Not to Treat. And thank you for that title. I would like to know the answer to that question myself, but we'll get back to that. So I have no disclosures. Just briefly, a little bit about the background. Tove already mentioned, but just to set the scene, it can have massive consequences, both occupationally and personally, including significantly reduced quality of life. The one-year prevalence is around 10% in the background population and 20% among healthcare workers. And as Tove mentioned, the disease tends to be chronic despite avoidance of triggering factors. The ethology is multifactorial and complex, and we wonder whether bacteria and the skin microbiota may play a role in this. So first of all, a little bit about the vocabulary. Because these terms are often used interchangeably, there are several overlapping definitions, and I don't think there is one definite definition. But overall, the microbiome is defined as the microorganisms and their genes, whereas the microbiota are the microorganisms by type. And then we talk about the good bacteria, the commensal probiotic, and the bad pathogenic bacteria, and then the opportunistic, which has the potential to both. When we talk about the microbiome, I like to look at it in this way, where we have the healthy and diseased skin. The healthy microbiome is characterized by a high temporal stability, a great diversity of the microbiome composition, and a high degree of skin commensals, whereas any specific pathogenic microbe is not present or very little. And as the skin diseases, these characteristics tend to shift. There are very few studies on the hand eczema microbiome, but we often compare these to the results of, for example, atopic dermatitis. And one of these methods that are often used in microbiome studies is one of these next-generation sequencing methods, the 16S rRNA gene sequencing. And that method differs from the culture-based method because it assesses the genes, so we get both the living and the dead bacteria. But we also get the relative abundance as well as the opportunity to identify several different genera at the same time. The skin microbiome is influenced by numerous factors, both from the inside and from the outside. And first of all, we will have a closer look at Staphylococcus aureus, because that's the bacteria that has been studied in most detail. So it's a gram-positive bacterium. It lives as a commensal in the human nose, but it has the opportunity to become pathogenic on the skin. It secretes violence factors, it activates the immune system, and it causes inflammation. But it is not completely known whether it is a cause or a consequence of this impaired skin barrier function. But I think that researchers tend to agree that it's a little bit of both. So based on these 6 culture studies, we know that the prevalence of Staph aureus in hand eczema is more than 50%. And this relatively high prevalence is significantly associated with the severity of hand eczema, but also having an atopic subtype of hand eczema. But I think it's very important here to note that we have observed Staph aureus in all different kinds of subtypes, so not only the atopic. And other than the presence of Staph aureus, the severity is also determined by the amount of Staph aureus, the density. And the next thought in that line was, we thought about, what about persistent colonization? So we did a study where we included 50 patients with hand eczema, and we divided these patients into 3 categories. They came to the department 5 times during a period of 3 weeks, and they were categorized as non-carriers if they were never colonized with Staph aureus, and persistent carriers if they were colonized with Staph aureus at all 5 visits. And based on this box plot, we do see that the persistent Staph aureus carriers had significantly more severe hand eczema assessed by the Hexi score. And other than that, we also classified these Staph aureus in each patient regarding to the subtype, the clonal complex. And we saw that the far majority of these patients who were colonized at least twice during these 5 visits, they had the same strain of Staph aureus. And another concept to think about with Staph aureus and hand eczema is the nasal colonization, because it has been hypothesized that there is this hand-nose-hand cycle where the nose is considered a reservoir for Staph aureus because it lives there as a commensal. And then the idea is that the patient can transmit the Staph aureus from the hand to the nose and then so on. And we have observed that there is a significantly increased prevalence of nasal Staph aureus in hand eczema compared with the healthy controls. And we also saw here that for each patient, in 75% of the cases, they had the exact same subtype of Staph aureus. And what is even more interesting, I think, is that each patient, they had, during this period of 3 weeks, they had the same subtype of Staph aureus in the nose and on the hand. So I think this gives us an idea that the Staph aureus is more of a permanent habitant of each individual rather than just a transient contaminant that gets in touch with this impaired skin barrier. And a study from China last year also found that the nasal colonization of Staph aureus was significantly associated with persistent hand eczema. So moving on from Staph aureus to the skin microbiome. We've done a study where we included patients with chronic hand eczema and compared them to controls. And we found that there were significant difference in the diversity. So here we see a box plot of the lesional skin from the patient, which is significantly lower compared to the non-lesional skin of the patient and also to the healthy controls. This alpha diversity can also sometimes be referred as the bacterial diversity or the within sample diversity. After that, we took the patients and stratified them according to disease severity, and we also see here that the diversity decreases with increasing disease severity. A Norwegian study from last year also found these results because they compared the patient who had never had hand eczema to those who had had hand eczema at some point, and they also found that they had lower diversity. And another result in that study, which I want to highlight here, is this relative abundance analysis. And I want to highlight that they found among these patients with hand eczema at the time of examination that they had a higher degree of Staphylococcus, which we would expect, but also the micrococcus, which the authors also say that that's more surprising result. So the third and last study I want to tell you about, considering the skin microbiome, is where we included 35 patients with moderate to severe hand eczema, and they were treated with a topical corticosteroid once daily for 2 weeks, according to guideline. And based on the culture study, we saw that the density of Staph aureus was significantly decreased following treatment, as well as the disease severity improved. After that, we wanted to look more into the microbiome data. So here we see the relative abundance analysis of the different genera, the 10 most prevalent in this. So it's divided here, L as the lesional skin and the non-lesional skin, pre-treatment and post-treatment. And what I think is very interesting here, again, is the Staphylococcus, which is very highly represented, in particular in the lesional skin before treatment. And after treatment, it tends to be more diverse. So obviously, we wanted to look more into Staphylococcus and see which specific Staphylococcus was present. Were there any sign that there was protective species, or was it just Staph aureus that's all over the place? So we were interested in Staphylococcus epidermidis and hominis as well, because that's been suggested to be important in atopic dermatitis. But we didn't see any significant difference here before or after treatment, nor in lesional or non-lesional skin. So, to sum it up, should we treat the microbiome? I think, based on these few studies, it's fair to say that there is an imbalance in the hand eczema microbiome, which is expressed by the reduced bacterial diversity, which becomes more pronounced with the disease severity, but also that improving the skin barrier function increases the diversity, and which we saw in the last study here. So I think for now, we should definitely treat the hand eczema, but I think it's more speculative whether we should treat the microbiome. Yeah. So that's it.
Thank you for this very interesting lecture. Yeah. Any questions? We have time for questions. Yeah. Sven Maldejon, yes. Please, Sven.
Yes, thank you very much for this absolutely exciting presentation, making clear actually what kind of importance Staphylococcus aureus has. We see so many patients from the health sector, and we have started to analyze all of them regarding the subtypes of Staphylococcus aureus, and we see quite many of them who have methicillin-resistant staph. And we feel actually if they run around in a hospital with having irritant contact dermatitis, the risk is so much higher that they do actually acquire methicillin-resistant staph. Have you got any ideas on that and any observations?
Are you thinking about the patients or the healthcare workers?
Yes, we just have patients which are healthcare workers, and knowing actually that they so frequently not only have staph in general, but if we subtype it, we find that they have the methicillin-resistant staph, which is a real problem in the hospital for spreading nosocomial infections. And on the other hand, running around with a hand eczema is something actually which seems to make it much more likely that they acquire this kind of bug actually. So for instance, if you do something against irritant contact dermatitis, you may also reduce the amount of nosocomial infections in hospitals. That's our experience, and I don't know what is your experience.
Yeah, well, thank you for pointing that out, because I think that's very interesting and a big problem. One of our colleagues did a study in hand eczema among healthcare workers where she actually sampled the Staph aureus on the hands of these healthcare workers with eczema. She found the prevalence to be around 10% of hand eczema, which was the half of what I started with in my presentation. And therefore, they had also, most of them, mild eczema, and the prevalence of Staph aureus was very much lower. But even though it was around 20%, it's way too many. And furthermore, if they are resistant to the antibiotic, I agree, we have a problem. Yeah. But on the other hand, if it was not resistant to the antibiotic, would we treat it anyway? Because we know from other studies on atopic dermatitis that they get recolonized with Staph aureus again. But yeah, I think it's better to treat the skin barrier function for now, at least. If that made any sense.
Yes, another question.
Thank you for this excellent talk. I would like to ask if this low diversity in microbiome in hand eczema was typical for hand eczema in the course of atopic dermatitis, or in the course of allergic contact dermatitis, or for both? Do you have the data?
We tried to divide these or stratify them according to subtype, but our data was too small for it. Yeah, we didn't have enough. So we tried to divide them into atopic dermatitis versus all the others, and we saw no significant difference. But I think it's too little sample size to tell about that.
There's time for one last question. I would like to ask you, Line, what would happen if we actually make the choice to treat these patients, and you say they will be recolonized? Do you think they'll be recolonized by the same strain, or will they have another strain of Staph aureus, and how will that influence the severity of the eczema?
I think also from the clinic that they tell their eczema improves following an antibiotic treatment, but I do think they would be recolonized. But it would be very interesting to investigate that further.
And will there be any influence of starting up a new strain on these patients? Because I think that we have some evidence from atopic dermatitis that if you make a change in the strain of Staph aureus, do you think that could influence the severity?
Yeah, I think the study you referred to, we did see that there were more severe eczema when they shifted the strain.
Yeah. Could that be the case here as well? Yeah.
I can guess. Yeah.
Okay. Yes. Questions online as well. Oh, I didn't know. Could you take them?
Sure. Yeah, we just realized that some people are either online or in the audience providing questions that we can read. So one question was, do you recommend using a combination of topical glucocorticoids and antibiotics in chronic eczema, taking into account diversity of microbiome?
Thank you for that question. I think it's a good question, and that's also, usually when I think about this presentation, as Caroline brought in, what's next, because is antibiotics the answer to this? And I don't think it is, especially due to the resistance. But I think we should stick to, when the eczema is clinically infected, then we should treat it with antibiotics. Otherwise, no. In my opinion.
And one last question here is maybe bring bleach baths
back. Yeah, sure.
Think so?
That's a good option as well.
Thank you again for an excellent talk. Thank you so much. And I'd like to call for the next speaker, which is Professor Margarida Gonzalo. And Margarida is well known, I think, for most of you. She's the sub-director of the university in Coimbra in Portugal. And Margarida has been in working with contact dermatitis for quite a few years, I could say, and you've been the president of the European Society of Contact Dermatitis a few years ago, and we are so happy to have you here today and to talk to us about important contact allergens in relation to hand eczema. Thank you.
So, good afternoon. It's really a pleasure to be with you, and thank you very much for the invitation. I'll try to share you some of my experience with you on this aspect. These are my potential conflicts, but they have nothing to do with this presentation on hand eczema. This disease that we have already seen is really sometimes devastating and really having a lot of influence in the quality of life of these patients. We also have seen that only looking at our patients, at the hands of our patients, we cannot say if there is any contact allergy associated or not. So we have really tried to answer these questions. Is there a contact allergen? Also, when we find a contact allergen when patch testing, is it relevant? And it's really important because if it is relevant, and if it's possible to avoid it, we can eventually cure some of the cases of hand eczema. Even though we know it's multifactorial, and maybe not only the contact allergy is responsible, but maybe in some cases we can cure the disease. How frequent is it, and which are the allergens? I will try to answer you on these questions. So how frequent, and if we go to these data on the frequency of contact allergens in hand eczema, it can vary from 20 to 80%. Of course, it depends if you include, first on the recruitment of patients, also if you include professional, occupational, or non-occupational cases, adults or children, this may vary. So most of cases, most of the studies are on occupational contact dermatitis, mostly in hairdressers, healthcare workers, dentists, nail estheticians, but we understand that they are really repetitively exposed to the same allergen. So the potential of sensitization is much higher. So this cumulative exposure can be important. Also, many of these patients have are exposed to wet work, use of gloves that may enhance the penetration of allergens. Some have concomitant irritant contact dermatitis that really may favor and enhance the hand eczema in this setting. But we'll be speaking about mainly non-occupational. And outside the occupation, in your daily life, there are a lot of possibility of exposure where you can get allergens and induce allergic contact dermatitis in hand eczema. But I put this red circle there because actually there are many allergens that you find both in your occupation and in your daily practice, like biocides in the shampoo and in some cooling fluid that you are using in the factory. So there may be many common allergens. So it's a little bit difficult to distinguish what is occupational, what is non-occupational. And here are the allergens that are more frequent. And I just put here epoxy resin because when we think about epoxy resin, we almost always think, oh, it's occupational. But we recently know, quite many years ago, I won't tell how many but we published this case in a patient that was allergic to epoxy resin, but it was during his hobby. He was playing billiards and he had prepared this stick with a varnish that contained epoxy resin. So that was the cause. So we cannot say this is always occupational and this is always non-occupational. And what about children and adults? All the studies, both on children and adults, they always find the same 3 or 5 main allergens. Nickel sulfate, methyl isothiazolinone or other isothiazolinones, fragrance mix, eventually other metals and biocides. And we may ask, is nickel relevant? In some cases, it can be. So this is an example of a young boy that was a guitar player, and we saw that the strings were positive for nickel. So we could explain his dermatitis, and he really improved. Or we may have this case of a lady that was doing some sewing, and we found nickel here in the scissors, and you see the dermatitis was really in the areas of main contact with the metal. And we know that if we have atopic dermatitis, or even without atopic dermatitis, if we have filaggrin mutations, there is much more penetration of nickel, and there's an enhanced also capacity of sensitization to nickel, and eventually also to polysensitization. But probably during this barrier defect, we know that dendritic cells in the dermis or in the dermis and epidermis are usually much more activated. Even in atopic dermatitis, we see the dendrites coming up these tight junctions. So these patients are really more prone to be sensitized to nickel and have nickel as a relevant exposure to induce their dermatitis. Other cases, as I told you, are due to isothiazolinones. And even though, at least in Europe, they have been only present in rinse of cosmetics, there are a lot of domestic household products where you can find this chemical. And what is interesting is that there are so many areas where you can get exposed that you can easily get the threshold, the amount of chemical that is added to your skin to induce the reaction and induce the allergic contact dermatitis. And you have to be careful because sometimes you don't see the real title, MI or MCI-MI, and you see them under different names like ketone, CG, or this, which is not so frequent. And remember also, for children, slime contains methyl isothiazolinone or other isothiazolinones and can be the only responsible for allergic contact dermatitis, or can occur or can aggravate atopic hand eczema. So you have to test even younger patients. And in our experience, we had a lot of cases of hand eczema due to artificial nails, so glue nails that, gel nails that contain metacrylates. And we have seen most in nail technicians, but also in our study in the CDRG, we found that almost half or due to non-occupational exposure, especially in the north of Europe when they have the home kits to their own nails. And what is interesting in this case is that, and we were trying to find the best gloves to protect the patients, and we applied the test with gloves here below and without gloves, and we just applied for 1 hour or half an hour the patch test, and we cleaned the skin, and you see that this beautiful positive reaction. So very short exposures to the acrylates may induce the reaction. So it is not really needed to be a nail technician and be highly exposed to have this allergic contact dermatitis. And we have published, and there are other cases of children that begin already this procedure and get sensitized to the acrylates with hand dermatitis. And in the south of Europe, we have a lot of garlic in our food, so we have a lot of patients sensitized to food. We had a lot of patients sensitized to these plants that they grow in their garden, which has the same allergen as tulip bulbs, and we are in Holland, we have to remember tulip bulbs. But most of them were non-occupational. And I want to stress, apart from the contact allergens I've been speaking about that usually induce delayed type hypersensitivity, I want to speak about immediate reactions that we see quite a lot in hand eczema. Not only contact urticaria, but especially this form of protein contact dermatitis that immediately on exposure to usually a protein, and usually in a previous lesional skin, you get immediately this vesicular reaction, as you can see here. But what happens is if you have very frequently this reaction, then you may develop chronic hand eczema. These are the main allergens. Most are, of course, occupational, but a lot also in consumer products, especially in contact with the food. It's our experience to see many of these cases. And for this, you have to do lesional testing, open or with a patch test. Like you see, we placed here this piece of lettuce, and you see within minutes we had this vesicular reaction. Or in other cases, you have to do prick testing or prick testing with, for instance, with fresh food. And doing this, we found that in hand eczema patients who reported immediate symptoms, about 50% had positive and relevant reactions to this food. So you have to think about these immediate reactions. And I was always puzzled, why do these patients have these vesicular reactions? What is the reaction, especially with IgE and T cells that is thought to be involved in this situation? And actually, there are data that support this IgE sensitization may rapidly involve Th2 and then other T cells. So we know that especially in hand eczema, we have, in atopic eczema, we have IgE on Langerhans cells, and for a long time we knew that it was said that these IgE-laden cells could present antigens to T cells and on a very strong way. But recently it has been shown that these activated Langerhans cells or other dendritic cells or monocytes that carry these IgE, if they come in contact with these allergens, these protein allergens, they can have what they call facilitated antigen presentation to these Th2 cells. So I think this may explain why these patients immediately on exposure to these proteins have these reactions. And these authors from Japan have shown that have shown that on the, what we call a topi patch test, we can have these Langerhans cells really covered with IgE and induce this spongiotic dermatitis. They actually say that spongiotic lesions of atopic dermatitis may represent a kind of a protein contact dermatitis. So we have to be aware of this. This is their explanation with the IgE-laden dendritic cells, calling the recruitment of Th2 cells and then Th1 and inducing this spongiotic dermatitis. So this is one explanation. So as a summary, if you really want to try to find some cause and alleviate this disease that can be really troublesome, you have to do a good clinical history. Think always about skin testing, and not only patch testing, but also prick testing. And of course, afterwards, you go back to the clinical history to see if it's relevant and if you have to avoid or not that allergen. And with this, I thank you for your attention. And I repeat also this image because we were both in Monaco, and I seem to have hand eczema following me, and it's where I think this is a very nice picture of hand eczema, even though the sculpture, I don't think he was really trying to represent hand eczema, but I think for us it's a wonderful image to represent hand eczema.
Thank you so much, Margarita, and you're really an expert in contact allergens. We have time for just one short question. Maybe I can ask you one short question, and that is, we have heard also at this Congress about emollients and emollients plus and so on. And do you actually, some of these emollients, they will contain fruit substances, cereals, wheats, and so on. Do you think it's a problem? Do you see reactions to that if you prick test, or have you any experience there?
Yes, some of these emollients, they can eventually induce these immediate reactions. And I have few experience, but Anne Gossens has reported eventually reactions to a cereal that is contained in some of these emollients. So people who are sensitized to grains, to cereals, can eventually react to, I think it's avena. I can't remember the name in English of the chemical, but they can be responsible for these reactions. And some of them, I think, they do not really protect fully from the exposure to the allergens. So emollients, and I think another problem is that emollients are not all equal. We have to, even when we compare their effect in atopic dermatitis and in hand eczema, we should look precisely at the composition of the emollients, because they can have an important influence. Apart from causing or not allergic contact dermatitis, they can have different influence on the skin barrier and the protection or treatment of hand eczema.
Okay, yes, that's really a huge topic. We will invite you to talk about that another time. Thank you so much. And our next speaker is Professor Sven Malde-Jon, and he has his own department, I would almost say, in Osnabrück. And Sven is an expert in prevention of hand eczema, and I think Sven is very well known to most of you. So it's a pleasure for us to have you here today, Sven, and talk about occupational hand eczema. Thank you.
Thank you so much, dear Tovi, and hello, ladies and gentlemen. Obviously, we've heard that IEC really needs to be present in public in order to improve the options which we have for treating our patients with contact dermatitis, hand eczema. And for achieving this, it's not enough that we are being able to read the writing on the wall, but then actually that also political stakeholders are able to do that. And for that reason, it may be very helpful to address the fact actually that hand eczema so frequently is occupational, and this obviously has some kind of a well, socio-political impact and can be used as leverage for us actually to improve options for treating patients overall. Considering actually that, for instance, education is something which is emphasized in all guidelines, also in the European guideline, which Professor Agner actually has chaired together with Jacob Thyssen. And in practical life, we know it's difficult to do that. I mean, do our social insurance system allow for educating patients with hand eczema? Do they really do it? Well, in case actually it's occupational, at least in my country, this is possible. And considering actually that we have in Germany something like 20,000 cases each year of occupational contact dermatitis, which usually actually is hand eczema, 90% of this is hand eczema, and that we know that most of these cases would be preventable if we just did it, and many of them are reversible, and that this has got quite some economic costs actually, and also does represent a large proportion of occupational diseases, costs in the range of 5 to 8 billion euro each year in the EU, which is also at the same time the cost of negligence if we don't do something about it. So I think all these data actually can be used in order to do something for improved care of our patients with hand eczema. Now, in order to achieve this, we have tried to make the UN institutions aware of the problem of hand eczema, and that has been very successful in terms of the International Labour Organization, who has now published this diagnostic and exposure criteria of occupational diseases, where you find a lot about hand eczema and its prevention. And also WHO has been extremely helpful in making it possible actually to code for occupational contact dermatitis, for occupational hand eczema. And what we have reached actually, thanks to particularly Anna and also to our further colleagues actually who have worked into very intensively actually to make it possible that we have a wide spread of coding options with the ICD-11, and we can also code exactly for the localization, for instance, dorsum of the hand, and we can, this is absolutely new, code for whether it's occupationally induced or not. So if we would make use of that ICD-11, the true magnitude of the problem would be revealed, and that would help the International Eczema Council actually to make clear what kind of important disease they are dealing with. And unfortunately, even though the ICD-11 is already in force since 2022, you can absolutely use it. It's in the internet. In most countries, it's not yet implemented, and I think we should also work on the fact that this is soon implemented in order to actually make clear what kind of problem we all are dealing with. Obviously, with the IDS, we try to convince WHO that there should even be pictures in the ICD, and we have advanced pretty far with that. Also, we have created within our EU standard project, and Professor Agner was part of that, the minimum standards of what should happen with patients who have had the bad luck actually of getting an occupational skin disease, particularly obviously occupational hand eczema. And we have postulated an interlocking system of primary, secondary, and tertiary prevention, making clear that also diagnostic is absolutely essential, patch testing particularly, and also education is needed. And we all know that this is some kind of postulates, but in most real-life scenarios, in most countries, actually, this will still be illusionary. So definitely we have to work on improving the options which we have to care for these patients. Also, all these postulates are in our European guideline, that there should be hands-on skin protection seminars for people who have the problem of having a hand eczema, also that there should be tertiary individual prevention programs for those actually which have not actually shown any improvement on secondary prevention measures. And we are in a rather favorable situation in Germany, which having the accident insurance, which is responsible for all these cases. And they also have to pay retrainings and pensions, so they have a great interest in actually doing prevention, and that's exactly what they enable us to do. So with the initial irritant stages of contact or hand eczema, contact dermatitis, we have the option of having special treatment by a dermatologist at very comfortable rates, and also having hands-on skin protection seminars for the patients. And if this doesn't work, then we even have the option of tertiary prevention, of putting them as inpatients. This is something actually in many countries. This will create some kind of astounding aspects actually, that we put patients with hand eczema as inpatients, but we really do it, and I will tell you about the experience which we have. But before I do that, obviously what we want to do is just to avoid that hand eczema happens, so doing primary prevention. And in Germany, we run a week of occupational dermatosis, wood, once a year. This year it's in November. And we also have this slogan, your skin, the most important 2 square meters of your life. Obviously, at this time of the day, actually, you might think that your bed actually is the most important 2 square meters of your life. But you're here, that means at least for some time you can do without your bed, but you couldn't do without your skin. And this is what we try to convey to politicians. And you are absolutely invited to use this slogan. And it can actually be translated, as we found out, in most languages. It's amazing, maybe even your language. And make use of it, actually, and join the EADV Euro Prevention campaign, Healthy Skin and Work. And if you do this, you will also please this gentleman, actually, who is the DG of the WHO, and who has recently assured me that he finds that this kind of activity is an awareness campaign he particularly likes. Now, let's go back to these patients who did not respond to primary and not to secondary prevention, and who have, for instance, have abstinence from work. And for these patients, we do not refrain in Germany for taking them as inpatients for 3 weeks in order to be able to do proper diagnostics, to teach them and to start therapy, so making sure that once they come back to work, everything actually is set in a way actually that the likelihood of a recurrence is as small as possible. And they do not go back to work once they leave the ward. Actually, they have another 3 weeks actually at their local dermatologist in order to have 6 weeks actually for regeneration of a perturbed epidermal barrier. And then once they return to work, they are continuously looked after by the local dermatologist with much better knowledge and with much improved ways of protection at the workplace. And this is what we frequently find. Obviously, our idea is to make sure that communication with the patient is not just an illusion. And we see that they, in male jobs, like to use crude brushes and abrasives for cleaning their skin. They would never do this with their cars. So if we manage to make them treat their skin as they treat their cars, actually, definitely they are much better off. Actually, avoid actually that they use high pressure air and organic solvents for cleaning the skin, or using these kinds of towels actually with all the allergens and irritants of the workplace safely stored there. And then with minor changes, you can reach a major difference actually in the occupational exposure. Also, we do some haptic experiments with them actually, for instance, the sugar cube, ones with protective cream, ones without. Putting a styrofoam block actually into a glove, putting the whole thing in acetone, and then see that within the glove actually the styrofoam is dissolving, the glove is not, making clear actually that you have to observe breakthrough times with gloves, trying to generally create some kind of a love-love relationship with gloves actually, and trying to do something about dangerous myth. It's fate, I can't do anything about the fact whether I get contact dermatitis or not, and so on. And also our colleagues from Gentofte actually have shown that hairdressers are not able to remove gloves without contaminating themselves. And even once they were told, actually, in the second round, actually, almost 60% were not able to do that. So that's a simple thing, actually, but it needs to be trained, and it can help a lot, actually, to reduce occupational exposure. And if you have this cook, for instance, actually where we learned actually that he will definitely be colonized by staph and shouldn't actually be preparing any kind of food actually without having gloves. But at the moment he doesn't, so we try to change this actually, and once he's been on the ward, he will get a starting package with all the various gloves he might need for the various procedures actually he does at his workplace. And he also get a glove recommendation with the suppliers, so that employer then can step in actually and make sure that in the long term actually he is provided with everything he needs at the workplace. And if you do it that way, actually our experience is with a large cohort of patients with severe occupational hand eczema, that you can really change the situation dramatically, that 82% are still working, where most of those patients with severe hand eczema without actually these kind of measures would probably have dropped off from the job. 80% are in the same profession, actually 73% exactly in the same job, but with much better knowledge and with optimal protection. And this actually leads to the fact that sick leave due to occupational hand eczema is crumbling down to virtually nothing. And obviously there are non-responders, no doubt, particularly if, patients actually who have a very severe atopic trait. But as we've heard before from Professor Agner, actually looking after 5 years to patients actually with chronic hand eczema, it seems there's not much change. So more or less from the literature, you'd say chronic hand eczema is something which is virtually incurable. And I think the reason for this is that patients with chronic hand eczema in so many countries are sort of left to the native course of the disease. And if we do this with syphilis or HIV, actually what's going to happen is that patients will die. Hand eczema is not lethal, but I still think we should do everything what we can in order to improve their prognosis. And definitely with these patients, we can say that their prognosis isn't as bad as you might assume going through the literature. At the same time, actually, from a health economic point of view, you can save a lot of money. These patients actually with severe hand eczema do cause tremendous amounts of costs actually, and once they have undergone the measure, we can see actually that the costs actually that are spent on average is reduced by 70%. And if we look in the rather precise data from the German accident insurance, we can say that due to these kind of measures, the amount of money they had to spend for retraining measures, which may be something like 200,000 euros for one patient for retraining, because they really have to cover everything that is related to this, have been reduced by 81%. So they like it. And then actually the same procedure actually was introduced in Austria, which has got a rather similar social insurance system. For that reason, it was relatively easy. And Professor Arbauer actually has had established a facility actually for also doing this tertiary inpatient program. And the outcome is actually that the number of notifications and acknowledgements of occupational hand eczema has increased due to the raised awareness, and the number of job losses due to hand eczema has drastically been reduced. And there's recent data actually from Denmark where they tried a similar system, and even though the whole study was a bit overshadowed by COVID, they can say that the kind of multidisciplinary intervention was actually decreasing the severity of hand eczema in the intervention group rather than compared to the control group. And now, ladies and gentlemen, close your seatbelts actually and have your tray tables fastened. Basically, actually, it could also work in your country. So if you're searching for that one person that might change your life and the life of patients with chronic hand eczema, just look in the mirror. Thank you very much.
Thanks a lot, Sven, for this excellent talk, and it's really interesting, and I'm so impressed by all your preventive efforts. Are there any questions? We have time for just one short question. I was thinking, I'm impressed by the secondary prevention, the tertiary prevention and also by your primary prevention, because I love this slogan that the two most important square meters in your life, that's your skin. But is it possible to measure the effect of primary prevention? That's always very difficult, isn't it?
Indeed, actually. Obviously, there are some data saying actually there's a return on prevention of something like 1 to 5, actually. Obviously, we will put our money in the bank, actually, who could provide actually this kind actually of interest. But it's always difficult to measure, and particularly if you look at it for a whole country. I mean, what we can say actually is that the accident insurance can actually give you exact data of how much money they expect to be saving due to these measures. That's why they do it. And actually, there's one more thing which I might like to add, if I may. We're trying to even further raise the emphasis of the WHO on skin diseases on the whole, and eczema is a very important part of it. And we want to have a resolution of the WHO for all skin diseases, and it seems at the moment that we might be able actually that with the next session of the WHA, the World Health Assembly, where all the health ministers of the whole world, 194 member states, are coming together actually in next May, it might actually work, and that would give us and the IEC another leverage actually to make clear that you are dealing with something which is very important.
Okay. Thank you. So we will have a short break now, no more than 8 minutes, and then we'll be back 8 minutes, and we'll be back on our seats.
A little bit, yes, I can hear me now. Great. So this is the last afternoon, last half session of the last day. Our next speaker, and we want to be on time, and we're on time. So our next speaker is Dr. Lawrence Eigensfield, who's Chief of Pediatric and Adolescent Dermatology at Rady Children's Hospital in San Diego, California. He's also Vice Chair of the Department of Dermatology and Professor of Dermatology and Pediatrics at University of California, San Diego, UCSD. He's a very well-known dermatologist who has done research and published in numerous areas, including atopic dermatitis and hand eczema. He has authored more than 400 journal articles, chapters, abstracts, and books. But the most important thing, I didn't say it yet. He's our president-elect. He's IEC's president-elect. Larry.
Thank you, Robert, and I thank the IEC for including me in this session. And I'm actually quite passionate as someone who spent a lot of time on atopic dermatitis. I've become very interested in chronic hand eczema in children, with the takeaway being that I'm very interested in it partially because there's not as much study of CHE in children as we need. So, see to bring it forward. Thank you. I was given the title of Treatment Strategies in Preventing Progression for Hand Eczema in Children, and we will get to therapy, but I'll put it in context of the thoughts of where we're at with hand eczema research. So we do a lot of investigational work in clinical trials in San Diego, but everything I discuss is based on evidence-based recommendations and published well-designed studies, and I really won't go into any of the therapeutic trials on hand eczema. So where am I coming from? Well, I want to give a pediatric perspective on hand eczema, and to a degree, a U.S. North American perspective. And we were just talking at the break about what a discordance there is between the incredibly good set of work that's been done in chronic hand eczema, including some children from Northern Europe, but the paucity of information that we have, especially from the US and North America, especially when it comes to children. So we will use by convention, when I'm talking about CHE, it's as per the usual definitions. But I will also wrestle with the issue of atopic dermatitis in association with chronic hand eczema in children, because while we have risk factors of chronic hand eczema being associated with atopic dermatitis, I don't think we have really strong data of what percentage of children at different ages who meet criteria for chronic hand eczema may have active atopic dermatitis or a history of atopic dermatitis themselves. So my questions to set up the discussion is CHE the same in children and adolescents as compared to adults? Are the associations the same and at the same rate? And that includes active atopic dermatitis with chronic hand eczema, prior atopic dermatitis with CHE, allergic contact dermatitis with CHE, and then irritant dermatitis in non-atopics. So the epidemiology varies depending upon the data sets that you take a look at. We know that it's 27% of men and 35% of women reported their first episode of hand eczema occurring before age 20. In Denmark, data has a prevalence of approximately 1.6% of chronic hand eczema in children, but other data has a one-year prevalence of 14.3% in young adults. The North American database is rather thin, I would say, with a very broad range from 0.9 to 4.4% in preschool and school children. But in one study, they reported a one-year prevalence data in teenagers of 10%, which is, I think, maybe real and remarkably high. Risk factors for childhood atopic dermatitis include atopic dermatitis, female sex, allergic rhinitis, which I think just correlates with a atopic tendency, and nickel allergy very specifically. But there's limited data in pediatrics, especially in the US. So symptoms of chronic hand eczema in children and adolescents, just the basics. They're going to mimic CHE in adults, but there are a few data sets that have looked to quantify symptoms and signs with really variable ranges. So pruritus, essentially a common part of CHE. Erythema reported 62% in one study, but I think it really depends upon how their definition is of someone with CHE and the findings that they see on that particular day, as well as xerosis. It was an interesting recent study which was looking at increased occurrence of hand eczema in children. Again, a Danish cohort that reported by parental report about a quarter of patients who had moderate to severe burning with a significant amount of pruritus and pain, and some degree of sleep disturbance, but less than that we see with more severe atopic dermatitis patients. The severity of chronic hand eczema. So now I'm going to go to my clinical situation, right? When I see patients having become more alert to hand eczema in children, we find that many times it's tied to active atopic dermatitis or a history of atopic dermatitis. Then when I go to the literature, studies relate a real variable severity of population in the population. In one study, there was 133 children and they reported symptoms of hand eczema. The study was 133 children who reported symptoms of hand eczema within the past year, but 44% lacked any signs or symptoms at the time of evaluation. 13% were reported to have moderate disease, and 14% had severe disease using the hand eczema extent score. And if you start searching for populations of what severe chronic hand eczema might be in children, it gets to be a very limited literature. I mean, you could find there was a study that was looking at systemic retinoid therapy, and that population had to have severe chronic hand eczema to get into the study, but it was 9 children in that particular study. Localization of CHE in children, it's remarkable the variation in these studies. I mean, I'm not going to drag you through each of the data, but if you look, it says dorsal hands, palms, and fingertips in different studies with different cross-sectional or retrospective observational studies. You get a marked variation in terms of whether tops of the hands or palms are involved, fingers, et cetera, and I think we probably need to do better morphologic descriptive studies in chronic hand eczema to move the field forward. The largest association of CHE is clearly with atopic dermatitis, what percentage of children or teens with AD have hand eczema or CHE? It was approximately 44% in one study of very young children, 0 to 2 years of age. In 3 to 12-year-olds, it was around 54% in another. And then the relative risk of developing chronic hand eczema in patients with atopic dermatitis is obviously markedly higher, with rates of 3.7 or 5.6 relative risks. Others are reporting a little bit lower. My translation to clinical practice is that let's take a step back. I was recently at a meeting of atopic dermatitis experts, and the question of hand eczema came up in that discussion, and they said, children hardly have hand eczema as part of their atopic dermatitis. And it was like, the pediatric dermatologists in the room were like, what? What are you talking about? It's like it's very, very common across the ages. Now, they may not necessarily meet CHE criteria, but many do because they have persistent disease for many, many months or recurrent diseases. So I think this is I wrote, there's the rub, so to speak. I do think I would like to have better studies that are looking at the atopic diathesis in young children with atopic dermatitis, and then whether their severity of atopic dermatitis will predict the course of the disease, because we do not have very good longitudinal studies on that. Recognizing the relative paucity of knowledge in North America, we set out to set up a few studies to look at chronic hand eczema in children through the Pediatric Dermatology Research Alliance. We call these the CATCHES studies, the Children and Adolescent Chronic Hand Eczema Study. And this included the first study was a survey of pediatric dermatology individuals with an interest or expertise in chronic hand eczema. Not the strongest data set, but it was a survey to ask them their perspectives on both diagnostic practices, evaluations, and how they layered what their therapies would be for atopic dermatitis, and really to lay the foundation for future observational and therapeutic studies. So we did have the assistance of Jacob Thiessen in the design of the study, and the first CATCHES study was published. So a few takeaways from this. In asking the individuals what percentage of patients they believed who they saw with chronic hand eczema had atopic dermatitis, most of the respondents, 80%, believed that 50% or more of their CHE patients had either concurrent active atopic dermatitis or a history of atopic dermatitis. This can be answered, obviously, in a prospective study more clearly, but that's the perspectives. I was very interested to see what studies were done on the average patient with chronic hand eczema, and the answer is we know that there's probably less contact allergy testing being performed in the United States, and that was represented by some of the data set. So we looked at the frequency of utilization of diagnostic testing for pediatric CHE, and essentially what you see is that 40% of the individuals only did contact allergy testing 1 to 5% of the time, and occasionally individuals would do bacterial culture or fungal culture. The other way of looking at this is that the contact allergy testing, you can see it was only about 20% of individuals who would consider that 50% or more of the time. So a takeaway is that there's not as much allergic contact dermatitis assessment being performed, even in the hands of people who are interested in chronic hand eczema amongst pediatric dermatologists, and something that I think will have to, I think, push forward in the United States. Fungal culture occasionally being performed, skin biopsies very, very rarely, IgE testing almost never in this subset of individuals. So I think there are some reasons why people might be underutilizing patch tests. They're performed 25% less of the time amongst US and Canadian providers in this survey. The why for that, I think, is mixed. I think there's less availability of allergic contact dermatitis in the US. Unfortunately, there is this reimbursement issue that happened with allergic contact dermatitis. Many dermatologists get paid in what's called an RVU system. It's a relative work value unit, and there is no RVU for physician services in patch testing. So many large academic programs suddenly would get no dollars for this very labor-intensive work, and it's really, I think, something that's not bringing the highest quality of care to our patients. I think also there's a lot of treat first and ask questions later, and we're going to roll over very quickly in other discussions about, I think, the evolving therapies for allergic contact dermatitis, which include topicals and systemic agents, and that may actually fuel that continued approach. So also I believe that there's concern with there's not enough real estate to put down your allergic contact testing, and also concern that you may be sensitizing individuals with broad antigen testing if it's not appropriately directed. So now I'm going to move over to therapeutics, which is and I'll start with sort of my thoughts about where we're at with therapeutics for allergic contact dermatitis in children. I think we lag behind. We lag behind in the basic research. We don't have a lot of work on guidelines. We don't have algorithms for our children or teens, and there's really a paucity of clinical studies. And even as we move forward to discuss some of our newer agents that have been studied in terms of nonsteroidals and systemic agents, the children weren't included in those studies for the first set. And while we say that children shouldn't be considered little adults, I think the therapeutics for CHE are handled just that way. They just are, they're handled as little adults without much work being done to look how things might be done differently. So in the CASHES study, we asked the U.S. providers what their first, second, and third line treatments of choice, and the punchline is that the first line therapy, 100% would use topical corticosteroids with discussions in the responses of various feedbacks. Second line split between either topical corticosteroids or calcineurin inhibitors, some topical PDE4 inhibitors, and rarely other therapies. Systemic therapies were hardly used, but what is changing, I think, is the evolution of nonsteroidals for pediatric atopic dermatitis, which are now being utilized for chronic hand eczema. And so we have both topical ruxolitinib approved in the United States, roflumilast cream has been approved, which is a PDE4 inhibitor, ages 6 years of age and older. A 0.05% lower creams, studies have already been improved. Tapinarof has been approved for psoriasis, but they completed trials in atopic dermatitis down to age 2. Topical crisaborole has completed a 1-year maintenance daily use study. This is all for atopic dermatitis. And then delgocitinib, we've certainly seen some very elegant studies at prior congresses and at this Congress supporting its utility for chronic hand eczema, recently approved for adults in an FDA filing, but not including children in those clinical studies at this point. This is an example of how I think novel nonsteroidals can help. This was a patient who had used high volumes of clobetasol and tacrolimus as his maintenance therapy. And in this case, he happened to have used, we moved him over to topical ruxolitinib. And he sent me a message in the EMR with these pictures saying, I don't know if I think I need follow-up. I've been clear for weeks. So, I think it'll be very interesting as we move forward with what may be more potent nonsteroidals to keep some of our patients clearer. Systemic therapy, in our particular study, it's hardly utilized by even our experts in pediatric contact dermatitis, but we're aware of the biologic agent studies that have looked at adult hand eczema, and there's the possibility of oral JAKs and retinoids you have experience with. There are a few pediatric studies where we don't have that approved in the U.S. So where are we with therapeutics? This is sort of my sense of the version of state of the art of what we need to do, and therapy should include, I think, more liberal evaluation with a more careful diagnostic evaluation in patients with more severe CHE, those who have a longer duration of their signs and symptoms, and those with more recurrences and flares. I think we should take a look at the context of CHE in relationship to other disease states and the comorbidities. I think we'll see more utilization of non-steroidal topicals, and should either as alternative monotherapies or in regimens of care with topical corticosteroids. And I think following the adult studies with systemic therapy, we can see these utilized much more liberally. It was hard not to listen to the discussions on microbiome changes and biomarkers without recognizing that many of those changes reverse very quickly with systemic therapy for atopic dermatitis and just haven't been tested yet in chronic hand eczema. So I want to end with like a high five for chronic hand eczema research. Like, instead of a call to arms, it's a call to hands. But I do think we do need to move forward with more research on pediatric CHE, both in terms of the aspects of the clinical manifestations and course, and certainly new therapeutics. So I thank you so much.
Thank you very much. We have time for at least one question. Any question from the audience? If not, I do have one. You mentioned that children don't tend to be patch tested as often as adults, and there's an issue where we practice, you and I of access to patch testing. Do you think that we should patch test children more? What I tend to see, I don't see that many children, I see more adults, but what I tend to see in children with hand eczema are mostly atopic patients that morph from a typical flexural type of atopic dermatitis to a hand presentation in adolescence. So do you think we should patch test those patients? And what about the non-atopics?
I agree with what you say. That's most of what we see, but I think we need to be astute clinicians and look at the clinical context to recognize those situations where we think contact allergy might be important enough such that we then do our intervention and sometimes change the lives of the patients. Because we do have cases where we pursue patch testing and we identify relevant allergens and it fixes the condition for those individuals. And I know it's hard to say just be astute clinicians, but I think we need to be.
Yeah, could I add just that I think it's important to patch test the children because sometimes you are so surprised they're sensitized to sport equipment and other things. So, yeah.
Thank you.
Very good. Thank you very much. Our next speaker, it's my pleasure to introduce Dr. Sonia Molen, who's Associate Professor, Division of Dermatology at Queen's University in Kingston. Unfortunately, or fortunately, depending on which side of the Atlantic you are located, she will soon be moving to Charité in Berlin in January. She's an internationally renowned expert in inflammatory skin diseases, including hand eczema. She published more than 80 peer-reviewed articles and book chapters, and she did some interesting research on pathophysiology of hand eczema. Dr. Molen.
Thank you so much, Robert, for the kind introduction. Thank you so much, IEC, for having me today. I'm excited to speak about topical treatment today. I do have some conflicts of interest to declare. So over the next 15 minutes, 20 minutes, my plan is to first cover a few of the challenges that we see in the treatment of patients with chronic hand eczema. Then I want to speak about briefly touch on a few general principles of topical treatment that are important to consider. Then I'll walk you through the classical, traditional treatment approaches, and then I give you a short outlook on what is new and what is coming. Only short because I know that Dr. Bissonnette will be giving you an overview on, a very detailed overview on everything that is new and interesting and relevant and will change our treatment landscape shortly. On my last slide, I will have some practical tips for you about topical treatment. Well, let's first talk a little bit about the challenges. Chronic hand eczema is challenging. It's frequent and it's chronic. So often when we see patients, we know we need to come up with a long-term management plan. We need to plan for flares, and we also need to plan for maintenance. Now, so far, our treatment options have been limited, and some of them come with a risk of side effects, particularly in the long-term run. This is not great because no one wants side effects, and then this contributes to poor adherence and poor compliance. Now, some general treatment principles for the treatment of hand eczema. Well, treatment choice should take into account the individual hand eczema of each and every single patient. And as much as I love to have a treatment that can address all hand eczema subtypes and all etiologies, all morphologies, I still want to know what kind of hand eczema my patient has. I want to know what causes it. I want to be able to identify trigger factors because I want to counsel on avoiding these causative factors. I want to know what it looks like because eventually I'll adjust my topical treatment depending on whether there is thick and hyperkeratotic skin or whether there's dyshidrotic vesicles, particularly when it comes to basic measures like moisturizers or skin protection recommendations. I also want to know how acute the hand eczema is. Is it very acute? Is it very chronic? Does it do repeated flares? And also, where is it localized on the hands? Is it more on the backs of the hands, which comes with different treatment implications for some of our treatments that we're using compared to palmicide, for example. And then it's also important to know, is there any comorbidities that I have to take into account for my patient? I think successful treatment and management of chronic hand eczema really requires a good patient-clinician collaboration, and it's often helpful to try to establish treatment goals together, because what the patient needs and hopes for might be different than what I'm hoping for. And it's good to discuss this and also sort of discuss ahead of time what are the needs for the treatment, particularly in the topical treatment. Are there some preferences when it comes to certain textures? Because I think that this really helps to empower adherence. We want to treat quickly and rigorously, hopefully early in the course of the disease, because we all know patients who have had chronic hand eczema for years and years and years. Two things to keep in mind, two goals for the treatment could be avoiding re-exposition to causative trigger factors before a complete healing of the skin barrier. This is great, and this is often doable in countries where there is support, particularly for our patients with occupational skin diseases, where we have the privilege to get them out of the job and help their skin to recover. In countries where there is 2 paid sick leave days, this doesn't work, so I have to be creative there, and it's often a goal that is not as achievable as we would wish it could be. And of course, we want to avoid prolonged exposure to potent topical steroids. I'll talk a little bit more about this in a moment. Now, how do we choose topical treatments? Well, first of all, it's important to keep in mind, in many of our hand eczema patients, a topical treatment, a topical anti-inflammatory treatment, together with good skincare, emollient use, will be able to control an acute flare. I often find texture matters, and it's important to talk to your patients about this, because patients will tell you what they like, and it is very important for the adherents to take into account patients' preferences. Often patients will tell me they will prefer a cream, and where I can, I follow with this. I follow with this and adjust my prescription. But sometimes, in some patients, I would prefer, for example, an ointment. Not so much in my patients with acute and oozing hand eczema, where I would add something drying or astringent, and also antibacterial agents in the topical treatment of their hand eczema. And I agree with what we have heard earlier on the skin's microbiome. I would treat antibacterial only if there's super infection. For our patients with hyperkeratotic hand eczema, we might want to add keratolytic agents to the basic treatment. Let's look at the guideline recommendations. So the European Society of Contact Dermatitis had published the guidelines on the diagnosis, prevention, treatment of hand eczema some 2 years ago. And if you have a closer look, let's see, if you have a look, you can see it's, and you all have seen this probably before. Here's the standard therapy or the basic therapy, basic measures like skin protection, emollients are recommended for every single hand eczema. And then depending on the severity, you'll see different treatment recommendations. Today I will only be speaking about the topical treatments. You see the topical steroids, tacrolimus, and phototherapy, and this is what I'm going to cover in the next few slides. First of all, topical corticosteroids. Topical corticosteroids certainly play a big role in the treatment of many inflammatory skin diseases and are still considered the mainstay in the treatment of hand eczema. Interestingly, there's not much data on the use of topical steroids in hand eczema. And a recent Cochrane review of hand eczema treatments found actually that only 9 studies with topical corticosteroids met the evaluation criteria. A few examples, random examples that I brought for you. For example, clobetasol foam in hand eczema improved symptoms but was not superior to the vehicle in a 2-week study. Then mometasone cream used only 2 to 3 times per week after the initial treatment course, where it was used daily, and that could have been up to 9 weeks, was able to maintain control of hand eczema. This sounds like a reasonable approach to me, like what we would do in clinical practice. Interestingly, and relevant in these studies, some of the patients had skin atrophy. And this is something that we really need to discuss. When we speak about the treatment with topical corticosteroids, we need to discuss pros and we need to discuss the cons. There's pros. Definitely advantages. It's a first-line treatment for many of our patients with inflammatory skin diseases, so also for hand eczema. It works well in the short-term run. I often call it the fire extinguisher. That's something how I discuss it with my patients. Also trying to make clear that this is not something that I want them to use like forever and ever. And it also can decrease the colonization of the skin with Staph aureus in diseases like hand eczema, and Lina has published on that, and this is also where we have heard and learned about this. So these are our advantages, but there's also limitations. And I would say the biggest limitations are the potential side effects, particularly if you do not use it in adequate texture, in the adequate body region, and if you use it too long and not in the correct way. It may cause all kinds of cutaneous side effects, including contact dermatitis. It's not frequent, but I've seen patients with hand eczema who have been sensitized to topical steroids. Interestingly, for hand eczema, very relevant, if you use topical steroids too long, it can impact or impair the epidermal barrier function. So in the short-term run, it helps. In the long-term run, it impairs the barrier function. It's not very helpful for hand eczema. And then, of course, people have concerns about steroids, and our patients have concerns, and it's important to address those and to also keep those in mind because they're relevant. And this might, again, interfere with compliance and adherence. So what do we do with the steroids? We sort of need them, but we also are aware that there's problems with them, particularly in the long-term run. Well, I think it's important to have a balanced approach, to use them when we need them, but also come up with a long-term plan that does not involve topical steroids, and also let go of the steroid when we see it's really not working. We really need to come up with a different plan. Carefully pick how strong the steroid is you use and at which formulation, and aim for the shortest possible treatment. I wanted to highlight this very good article that was just recently published by Dr. Oberländer Christensen on corticosteroid phobia in chronic hand eczema, because we know that corticosteroid phobia is a thing, but until recently there was not much data on what does it look like in chronic hand eczema patients. And this article, this publication looked at this topic and found that it's actually quite common in our patients with chronic hand eczema. And, surprise, it is negatively associated with treatment adherence. So it's definitely something that we need to keep in mind and that we need to work with. Let's talk a bit about the alternatives and the traditional treatments for hand eczema, the non-steroidal treatments. Well, in the guidelines, not much is mentioned because not much is there. You see, tacrolimus ointment is suggested as a treatment for milder to moderate hand eczema courses, and as you know, tacrolimus and pimecrolimus are approved for AD treatments, or they're technically not approved for chronic hand eczema other than atopic hand eczema. In the guidelines, tacrolimus as ointment is suggested for the short-term treatment of our patients with chronic hand eczema that are refractory to the steroids, to topical steroids, for patients who are afraid of side effects of topical corticosteroids, and in the chronic stage, so more like for maintenance. Data on pimecrolimus is actually conflicting and does not really show great benefit in the use of chronic hand eczema, and that's why it's also not mentioned in the guidelines. For completeness, crisaborole ointment is another topical non-steroidal treatment that could be used in chronic hand eczema. It is licensed in the US and Canada for the treatment of atopic dermatitis, a topical phosphodiesterase 4 inhibitor. So it can be used for atopic hand dermatitis, but there is no randomized controlled trials in patients with other forms of hand eczema. And a small retrospective chart review of its use in atopic hand dermatitis showed a benefit. I have seen patients who have used it in Canada and had a favorable response. I think at this point is we have so few options that we're excited about everything that works, and spoiler alert, there will be more coming. I decided to briefly mention phototherapy here as well, because phototherapy sort of is a topical treatment and is also mentioned in the guidelines. It's definitely not a systemic treatment when we treat hand eczema with it. Phototherapy can be used for patients who failed or are contraindicated to topical steroids. Narrowband UVB or local PUVA, either in bath or in cream form, are available. Data doesn't really say one is superior over the other. Data is also quite sparse. We believe that PUVA has likely more side effects. So the one or the other. I think phototherapy really is a good and classical treatment, but it comes with a huge limitation that it does not fit everyone's lifestyle. And by everyone's lifestyle, I mean it is really complicated to see a physician 3 times a week when you have a life or when you have a work schedule. So it is time consuming, and also access is limited insofar as not everyone can offer phototherapy to their patients, and patients do not have the ability to drive 2-3 hours to see someone 3 times a week, at least for phototherapy. Now, there's treatment gaps. I think that was very clear from the short overview in topical therapy, because there's not much we can use. And you've heard that multiple times before today, that there's some data looking at patients with hand eczema over a course of 5 years. It turns out that 2/3 of them, up to 65%, still continue to have recurrent episodes after the 5 years. So obviously what we're doing is okay, but it's definitely not great, and we definitely need to have more treatment options. Also, the steroids, topical corticosteroids, are definitely not suitable for long-term management, and they can impair the skin barrier function over time. So is not an ideal long-term treatment for various reasons. Until now, very few steroid-free alternatives. So we definitely need more treatment options that work well, ideally in all hand eczema subtypes, and also have the potential for long-term control. Now, there is, fortunately, good news, because there is new topical treatments in clinical trials, and new topical treatments just being licensed, as Dr. Eichenfield also mentioned before, and you probably have heard over the last 7 days. I want to briefly mention here the 2 JAK inhibitors, delgocitinib and ruxolitinib. Ruxolitinib is licensed in the US. Dr. Eichenfield also mentioned that for atopic dermatitis, so it could be used in label there for atopic hand dermatitis, a JAK1 and 2 inhibitor. It is currently there's currently 2 clinical trials for its use in chronic hand dermatitis or chronic hand eczema, and we're curious to hear more about this. Delgocitinib is a pan-JAK inhibitor and has gone through an extensive clinical trial program. The phase 3 trials have just been published in The Lancet with Dr. Bissonnette as the lead author. The phase 3 head-to-head comparison versus alitretinoin was presented here at the EADV. You probably have heard the really relevant results from this trial, and this is something that also interests me quite a bit. Phase 3 is going on in adolescent patients, because I agree with Dr. Eichenfield, we see so many pediatric patients where we would like to offer some non-steroidal treatment options in the future as well. Now, the good news is that just a week ago, delgocitinib cream has been approved for the use in the European Union. So over the next few months, we will see the first countries actually seeing this treatment in the pharmacies. I will not say more about this because I know Dr. Bissonnette will want to cover this. I just have a few practical tips for you. In the end, topical treatment in chronic hand eczema is challenging, but it will change a lot in the next little while we're adjusting to the new treatment options we finally have available for our patients. Still, we will all be using steroids in the first place in our patients. And what I find helpful is addressing the problems that might come with topical steroids in the first place. So when I see a new hand eczema patient, most of them already had some sort of topical treatment, some steroids. Often I find the steroids they have been using were too weak, so we couldn't expect any reasonable response. But I still will say, I will give you another steroid. We start with this. We try an appropriate strength. And do we love it? Do we hate it? Well, sort of both. We like it because we know it can help with the inflammation. But we also are not happy about potential side effects, so we will not use it in the long-term management. We will have to have a backup plan, something else that we can do. Then what I sometimes do is that I let my patients try samples of moisturizers and also topical treatments if I have in clinic. I find this is helpful. It's often also helpful in my pediatric patients where some of the moisturizers or topical treatments have caused significant burning before. They're really concerned trying something new that might help doing it in your office. I talk to my patients about how they like their treatment, how they like the texture, because I think it's important if someone says, I really hated it, and I know, well, we have to switch the texture and have to do something else. Keep in mind, hands are not hands, so the skin is different on the backs of the hands, and when we treat the backs of the hands, for example, with steroids, we definitely want to have a shorter treatment course compared to what we do for the palms in the first place. And then my last practical tip is I don't think cotton gloves overnight are a must. I often get asked by my patients, shall I wear cotton gloves over my treatment at night? They might have heard that from somewhere or have seen it somewhere. For me, it's 50-50. It's like they can, but they don't have to. It's like I feel like it's like sleeping with socks. Some people hate it, some people love it. So I leave this up to the patient. Well, I hope you found that interesting, and thank you for your attention.
Thank you very much. We have time for maybe one short question. So I have one short question for you. I don't know if the answer will be short or not. We have a talk about topical therapy. We have a talk about systemic therapy, but often when we use systemic therapy, we have partial responses. Is your approach the same in patients you treat with systemic treatment when you use topical treatments, or is your approach different? Do you have things that you prefer to use in combination with systemic?
That's a very good question. Don't think that there's a short answer. What I really like about the topical treatments, I'm a big fan of topical treatments. I use all the systemic treatments, but I'm really a big fan of topical treatments because I know we can add them on to other treatments if we need to, if we want to, or if the patient asks for that. I use the same armamentarium, I would say. I use the same armamentarium. My goal is always to try and use as little steroid as possible. I'd rather go for a stronger steroid, but for a shorter time period. And I find this is something that can also be added to a systemic treatment if there is, for example, a flare.
Very good. Thank you very much. All right. Our next speaker is Dr. Marie-Louise Stuttler. Dr. Stuttler is Associate Professor of Dermatology at the Department, University Medical Center, Groningen and Groningen. Her major interest is clinical and translational research in hand eczema, atopic dermatitis, and contact allergy. She's also a co-founder of the National BioDay Registry, which is focused on new systemic treatments for atopic dermatitis and comorbidities. And she will talk about systemic treatments.
Thank you, and thank you very much for the invitation. I will present data on systemic treatment of hand eczema. These are my disclosures. Yeah, you already saw the treatment guidelines. This schedule is from our European guideline. It's from 2022, so not all new drugs are included. I will talk about systemic treatment, and when we look at this table, we see not that many systemics included. Actually, alitretinoin is the only approved drug for the treatment of severe to very severe hand eczema. In Europe and in Canada, it's approved. And it's a recommended treatment, second-line treatment after failure on topical steroids. And then we have cyclosporin A. It's suggested, limited studies on cyclosporin. So the suggested is mainly actually a recommendation on expert opinion. And yeah, other third-line treatments are methotrexate, azathioprine, and astatine. Let's look a bit at available data. When we look at alitretinoin, this study was performed years ago. 1,000 patients were included with severe chronic hand eczema. It's always important to look at the severity of the patients which are included to interpret the data. And so there was severe chronic hand eczema. Patients were randomized to oral alitretinoin, 10, 30 milligram, or placebo. And you can see here at the PGA, they can see that 48% of the patients reached clear, almost clear. So half of the patients, and a lower proportion on the lower dose of alitretinoin. And for the patient global assessment, it was a bit lower proportion which achieved clear or almost clear. It's 40%. As we all know and can see from this table, it was well tolerated, but the side effects we always see in daily practice. Actually, a little bit of headache we see. It was around 20% in this study, and I think we should also see that in daily practice. Thyroid function disturbances a bit, most of the time subclinical, but an increase of lipids. But what also was clear from this study, that is a post hoc analysis, so it was not stratified when they performed the study. They initiated the study, but the post hoc analysis revealed that not all clinical subtypes achieved the same results, actually. So we can see here the hyperkeratotic hand eczema subtype. In that subtype, there was almost 50% clear, almost clear. And also fingertip dermatitis, 44%. But vesicular hand eczema, there was only 33% of the patients who achieved clear or almost clear. So vesicular hand eczema responded less, actually. Here I have a drug survival, a recent study from Denmark, actually. It is a very nice study. It is a real-world study in which all hand eczema patients that initiated alitretinoin in Denmark between 2008 and 2020 were included. It was the first prescription with a follow-up of 1 year. You can see here that 3/4 of the patients had hyperkeratotic eczema and 1/4, around 30%, actually non-hyperkeratotic eczema. But you can see from the drug survival that those with hyperkeratotic hand eczema had a bit longer drug survival. It was unknown what the reason was for discontinuation, because it was not registered. But what was interesting, actually, is that after discontinuation, 603 patients got a next systemic treatment. And of them, 350 patients were again treated with alitretinoin. So probably there was a reason that they stopped because of the registration of 24 weeks, and probably it was effective in that group of patients. But it was also important that around 250 got another treatment. So probably in those patients, alitretinoin was not effective. So yeah, from this you could conclude that we need more treatment for chronic hand eczema. Cyclosporin, very limited data. I would like to show you this drug survival is actually from the Netherlands to it. That's referral centers. And this study was performed already years ago, actually before alitretinoin was approved, because when there's a new drug approved, it will influence your drug survival. And what you see here, that the overall drug survival after at 1 year was around 45%. And you see here that you see an overall drug survival, the blue line, and you can also see that there were more patients that stopped due to adverse events than due to inefficacy. Looking at the overall reason for discontinuation was adverse events in 43% of the patients and inefficacy around 18%. So looking at male sex, it was associated with a longer overall drug survival. Yeah. And a couple of years ago, we started with a clinical study at our department, and it's a study, an investigator-initiated randomized open-label trial with blinded outcome assessment. And in that study, we compare alitretinoin with cyclosporin. And I will show you some preliminary data. We have now we have 60 patients included, so we have another 15 that we should be included. But I would like to show you some data. And this study is a study in which patients are randomized for being treated with alitretinoin or cyclosporin. And in the cyclosporin group, they start with 5 milligram per kilogram per day. And at week 8, we lower the dose of cyclosporin to 3.5 milligram per day. So a high start dose and then tapering the dose. And in this study, patients were followed up for 24 weeks. And important to mention that medium potency topical steroids were allowed. And for the study, we included moderate to severe chronic hand eczema, actually all types of hand eczema, all clinical subtypes. Here you can see the baseline data. Around 40% had a history of atopic dermatitis. Different subtypes included. You can see here vesicular hand eczema, around half of the patients. A few hyperkeratotic eczema, but also irritant contact dermatitis was included. A few patients were treated previously with alitretinoin and cyclosporin, but only a few. And when we look at the severity, then you can see that it was moderate and severe, very severe, was quite balanced. There were also a considerable proportion of patients that had severe to very severe hand eczema. And it's also reflected in the HEXI score. The mean HEXI was around 65, which is also in the severe range. And it's the same actually for the QOL-HEX score, the quality of hand eczema score specific for hand eczema, quality of life measurements. It also shows that there was a strong to very strong impairment in quality of life. So that's this population. And there I would like to show you some preliminary data. And what you can see actually at week 4, blue represents alitretinoin and orange cyclosporin. That you see at week 4 that there is a significant difference when we look at treatment response according to the photographic guide. So the endpoint was clear, almost clear, and then we see that after 4 weeks in the cyclosporin group, around 70% was clear, almost clear, and in the alitretinoin group it was around 30%. Probably, and it's important to realize that we started with 5 milligram per kilogram cyclosporin, so it was quite a high dose. But what you then see when you taper the dose of cyclosporin, because you want to go to an intermediate dose, then you see that over time that alitretinoin catches up actually. Already at week 8 and week 12, we do not see a significant difference anymore. And week 24, you can see that both for alitretinoin and cyclosporin, we have a proportion of 65%, which reaches clear, almost clear. Looking at HEXI 75, HEXI 90, the dashed line is HEXI 90, and orange is cyclosporin, alitretinoin is blue again. And you can see actually that there is significant difference when we look at HEXI 5 at 4 weeks and at 12 weeks in favor of cyclosporin. And for HEXI 90, we see a significant difference, a at 4, at 8, and at 12 weeks. However, at 24 weeks, you can see that the effects are similar. With regard to quality of life, assessed by the QoL-HEC, you can see here the proportion of patients reaching the MIC for the QoL-HEC, which is 22 points or above. And then you can see that at 12 weeks, so there is there's not significant difference, but you see that there is a larger proportion of patients on cyclosporin who reach this MIC. But again, actually a bit similar as the clinical data, you see at 24 weeks no difference in the proportion of patients reaching the MIC. So similar results for alitretinoin and cyclosporin. But I think these results are similar, but both are demonstrating quite good effectiveness actually. Very shortly about the dropouts, there were few reasons for the discontinuation. Some patients stopped at 12 weeks because of ineffectiveness, and there were also dropouts because of adverse events. In the alitretinoin group, 4 patients stopped because of adverse events, and in the cyclosporin group, 2 patients. And I have only here and were also the most important side effects, that were the subjective side effects. You can see in the alitretinoin group that we have that headache, around 20%, but a little bit of fatigue also. The question is whether it's drug-related. And when we look at cyclosporin, then you can see also headache as an adverse event, but also hypertension. So actually the adverse events we recognize from daily practice. So I think these results, we are looking forward to including the last 15 patients for this study. And then we'd like to publish all the results. And we think it's also important, although we are looking forward to new drugs, it's also interesting to look at conventional systemics. And on one hand, because of effectiveness, but also because of costs. Now we look at methotrexate. Methotrexate is even less studied, actually. I found this, we have this drug survival study of methotrexate, very small group, 42 patients. And we see here, actually, that around 30% still use methotrexate after 1 year. So this drug survival is less good than cyclosporin. But what you also can see that there are discontinuation is more because of ineffectiveness than adverse event, and we recognize that because methotrexate does not have that much side effects. Actually, so I think these results reflect also daily practice. And I think there were a few patients who did quite well and could stay for a long period on methotrexate. But most of them, they had to stop. Very shortly, another study we did a couple of years ago. We wanted to investigate the efficacy and safety of oral alitretinoin versus azathioprine. And we started a study in severe chronic hand eczema. And it was also a randomized open-label trial in adults with severe chronic hand eczema, in which one group was treated with 30 milligrams of alitretinoin and the other group with azathioprine. But unfortunately, we had to stop this study actually because of a high dropout. You can see it here. We had a dropout rate of 50%, and that is a reason to stop a clinical trial. And you can see here the dropout was in alitretinoin, it was 33%, so also quite high actually, but the highest it was for azathioprine. And the most important reason was adverse events. So that was the reason that we had to stop this study, but we published it because we also wanted to publish a prematurely discontinued study. Then we come to dupilumab. And dupilumab is not yet included in the European guideline, but it is already in label for atopic hand and foot dermatitis. And this study is a clinical study, 133 patients, adult and pediatric patients, 12 and above, moderate to severe atopic hand and foot dermatitis, randomized 1-to-1 to receive either dupilumab or placebo, and it was a double-blind placebo-controlled phase 3 study. Which patients were included? What we can see here, a baseline HEC 46, 47, so it's a bit lower than the other studies. Different subtypes of hand eczema, hyperkeratotic hand eczema, vesicular hand eczema. If we look at the results, hand and foot IgA, we can see here that at 16 weeks, 40% of the patients achieved clear or almost clear, compared to around 50% on placebo. And on the right, we see 4 or above point reduction in the hand and foot peak pruritus NRS, and we can see that 50% of those on dupilumab reached this endpoint. So that are very good results. And very shortly, also for other secondary outcomes like QOL-HEC, peak pain, HEC scores, all significant differences between placebo and dupilumab. So, and that's also based on this study, it is that dupilumab is also within the label now for atopic hand and foot dermatitis. But also would like to present data from our own department. We performed a small study, actually. It was a placebo-controlled study in which we treated 29 patients with severe chronic hand eczema, 2 to 1, to receive either dupilumab or placebo. And we included patients with recurrent vesicular hand eczema and chronic visual hand eczema. This was really a refractory patient group. You can see it in the HEC scores, 85. And most of them had several other systemic treatments. What you can see here at the primary endpoint, PGA, you can see that those treated with dupilumab, 70% reached this endpoint, clear or almost clear, compared to 33% in the group of placebo. And actually, we see also quite good results, similar based on another outcome, the HEC. On the left side, you can see percentage change in HEC. You can see for dupilumab, 88% change compared to 10% in placebo. And on the right, you see the cutoffs, HEC 50, 75, HEC 90, also very good results. Important to mention, in this study, only 5 patients with atopic dermatitis were included, a history of atopic dermatitis, and we did a sensitivity analysis, so we adjusted for AD, and we got the same results. So actually, this study demonstrates that also, dupilumab was effective in those without atopic dermatitis. And then the MIC, on the QOL-HEC, you can see here the proportion of patients that achieve the MIC on the QOL-HEC. You see that it's, when we look at 4, 8, 12, and 16 weeks, you see that it nicely improves. And finally, at 16, 70% of the patients achieve this MIC for the quality of life. Then one example of a patient included in the study, patient with very severe hand eczema for years, a lot of systemic treatment. You can see here the difference between baseline, it was a very severe hand eczema, and after 16 weeks, it was actually clear. So then, based on this study, we were also interested, because we excluded hyperkeratotic hand eczema. So I have 3 cases from our clinic, actually, with very clear hyperkeratotic hand eczema, 3 cases, 1, 2, 3, and were patients who had no history of atopic dermatitis, who had 2 previous systemic treatments. And you can see here, they were all 3 treated with dupilumab for 16 weeks. And you see that in patient 2 and patient 3, they were completely clear after 16 weeks. Patient 1 improved, but incompletely. And you still can see some hyperkeratosis, actually. But it's important to mention that he had occupational contact dermatitis. He was a bricklayer, was a smoker, so probably the irritant component was partly the cause that he didn't improve completely. We don't know. So in summary, according to the guideline, alitretinoin is the first choice systemic treatment in severe chronic hand eczema, especially for hyperkeratotic hand eczema. We have dupilumab now as an effective option for moderate to severe atopic hand eczema, probably also effective in other subtypes, but we need more data on that. With regard to cyclosporin, we showed early effectiveness within our study, and I think we see the same in atopic dermatitis, and we saw similar results after 24 weeks. Regarding methotrexate, maybe a third-line therapy for a subpopulation of patients. And azathioprine, I think it's as a third line included in the guideline, but consider the high dropout rate due to adverse events. Thank you for your attention.
Good. So we have a question from the audience. Can isotretinoin work for hand eczema?
Yes, because of this study we performed, at the moment we do not prescribe it actually anymore. But incidentally, there are cases that it could be effective. Yes.
Very good. Then we have another question.
Thanks for this great talk. I was wondering about your data about the success of alitretinoin. I have to say, clinically, I'm really underwhelmed by the retinoids for hand eczema. For vesicular hand eczema, and also for people, even if it's isolated atopic hand eczema, let's say they don't have any, active atopic dermatitis, but they do have a strong atopic background, maybe xerotic skin. I really don't see that it works. It's gotten to the point that if I give it to patients and it works, I kind of think they have psoriasis. So my question is like for people with atopic hand eczema, would that still be your first line? Because for me, I have to say, at this point, it's not. And did you stratify the data in the study, the cyclosporin alitretinoin study by indication?
Yes, so regarding your last question, we didn't do that, not yet, because we didn't include all the patients, but we want to look at the different subtypes in our study, yes. So we definitely want to do that. And regarding atopic hand eczema, actually I think a lot of hand eczema is mixed etiological type. So there's irritant contact dermatitis, there's a little bit of allergic. So actually, I do not see that much atopic hand eczema, only atopic hand eczema, without atopic dermatitis on the rest of the body, actually. Yeah, what we do in our clinical practice, actually, we start always with alitretinoin. Although, but it's only expert opinion, when patients have vesicular hand eczema, sometimes we go to the next step and start immediately with cyclosporin. Because in daily practice, we see actually a good effectiveness in atopic hand eczema with cyclosporin. So that's the reason we sometimes start with that. But it is only expert opinion, not based on clinical studies or guidelines.
Very good. Thank you very much. All right, so we're a few minutes behind. However, good news, you'll be able to be out of here before what's on the agenda, because we will not have the discussion section. We've had questions after each presentation. So I'll be talking about emergent therapies for atopic dermatitis, for chronic hand eczema. This is my disclosure slide. I'll be talking about a number of drugs today with which I do have conflicts of interest. I either served as an investigator or a consultant or managed studies for various pharma companies developing them. So when I prepared that talk, I decided to focus on future additions and define future additions by drugs that are not approved, drugs that are approved in at least one country, but not specifically for hand eczema. And I decided not to cover drugs that were approved for AD and studied in atopic dermatitis, chronic hand eczema. Now, my presentation was good and everything was fine up until a few weeks ago. And now it's not anymore because delgocitinib has been approved for chronic hand eczema. Dr. Mullen and I exchanged as to who will be covering delgocitinib, and I will be covering delgocitinib. So topical treatments, we'll speak at length about delgocitinib because it's relevant. It has just recently been approved in Europe. It will be approved, I hope, in Canada soon. In addition, there's a lot of data available for this product, and we have a limited number of products currently in clinical development for chronic hand eczema. So delgocitinib, as you've heard and you know, is a pan-JAK inhibitor. It's interesting to know that there's an ointment formulation that is currently approved in Japan for atopic dermatitis. The formulation that is EMA approved is a cream formulation. So this is a summary of the two pivotal studies, Delta 1 and Delta 2. So after screening, patients were randomized 2-to-1 to receive either delgocitinib BID or cream vehicle BID for 16 weeks. The type of patients that were included, patients with an IgA of moderate or severe, patients who also had pruritus, they needed to have at least a 4 on a scale of 0 to 10, and a medical history of inadequate response to TCS within the past 12 months. If patients did not have that within the past 12 months, we had to treat them with TCS and make sure that they had an inadequate response. The primary endpoint was IgA treatment success, 0-1, with a 2-grade decrease, which is the typical type of endpoint we do have in many of our dermatology trials. However, for those of you who may be less familiar with this program, the IgA scale that was used was a novel IgA scale that was developed by Leo specifically for that program. And following recommendations from FDA, the almost clear category only allowed barely perceptible erythema. So it's a very, very high bar in terms of treatment response, because you either have to be clear or have barely perceptible erythema. Anything else, any scaling, any residual lichenification on the back of hands, vesicles, anything, you're a non-responder. And the FDA is pushing more and more for this type of definition for almost clear for different indications. So in terms of baseline demographics, not surprisingly, more female than male patients. This study was conducted in Europe and Canada, so most patients were white. In terms of severity, IgA was moderate in 67% of patients and severe in 33%, and the median XC was 65. The LQI around 12. So these are the results of the primary endpoint. So these are the two trials. In the first trial, the proportion of patients who responded was around 20%. In patients randomized to delgocitinib, around 10. In patients randomized to vehicle, statistically significant. The delta was larger in the second trial, where it was close to 30% of patients who responded IgA 0-1 with a 2-grade decrease, as compared to about 6 or 7 in patients treated with vehicle. When we look at other endpoints, XC, so XC75, for example, almost identical in the two trials, 49%, 49%, 49.5, 49.2. XC90, 29% versus 31%. The LQI, 3-grade decrease, 74, 72. All these differences between active and vehicle were statistically significant. In terms of safety, the only thing that stands out is a higher proportion of dermatitis or contact dermatitis adverse events in the vehicle group, which is not surprising. This is what we typically see in studies conducted in eczema. The rest seems to be fairly identical. One of the things that is not written in those adverse event summaries and that I found in my patient, in fact, when I started the trial, I was a little bit worried because, as you know, many of the severe patients, they have fissures, and the patients with fissures are very, very sensitive with topical products. So I was afraid that this product would burn and sting, and in my experience in that clinical trial, it was not the case. It was really well tolerated. So long-term extension study, this was presented at American Academy of Dermatology earlier this year. So what happened after the first 16 weeks is that patients had the option to enter into a 36-week open label study. If they had an IgA of 0-1, so if they were responder patients, they had to stop treatment up until they came back with an IgA of 2 mild, where they would restart treatment up until their IgA went back to 0-1. So in terms of safety, this was the main reason why this study was conducted. There was no vehicle, so it's difficult to compare. However, you can compare patients who previously came into the study with delgocitinib as a treatment, so those who were randomized to delgocitinib in the parent trial, to those who were randomized to vehicle in the parent trial, and there's nothing very different in terms of adverse events, nothing stand out in terms of safety in this long-term extension study. In terms of efficacy, this is a proportion of patients who had an IgE 0/1 at each visit. The lines that are in orange are those who started with vehicles, so they started lower and then they went up. The triangles, the black triangle, are patients, the total population, and the circles, the green circles, are patients who started with delgocitinib. About the same thing if you look at XE75, so fairly flat throughout the study. This is data that I presented yesterday for the first time, which I think is interesting because it looks at efficacy in subtypes. This is a post-hoc analysis, but it was in that study, physicians had to determine which subtypes the patient had, which subtypes of chronic hand eczema. The options were atopic hand eczema, so this was the largest subgroup with about 36% of patients. Hyperkeratotic hand eczema was 21.5% of patients, irritant 19.6%, allergic 13.9%, and vesicular hand eczema 9.1%. There were a few patients with protein contact dermatitis, but no analysis could be done in these few patients. One thing that is important to note is that we could choose more than one. So an atopic hand eczema patient could also be assigned to vesicular hand eczema, for example. So this is the data from that sub-analysis. So those of you who sit far away, it might be a bit difficult to read. So I'll go through this one by one. So this is the total. So this is the entire study. In orange, you have patients randomized to placebo for the first 16 weeks. In green, you have patients randomized to active, and you have the delta. This is cumulative treatment success. So if a patient had a treatment success once, they're counted as one for good. So it can only go up. On the upper center, you have atopic hand eczema, and it fairly parallels total, not surprising because it's the largest group. On the right, hyperkeratotic hand eczema. So I was very interested earlier when we talked about maybe looking at biomarkers because this patient population is more difficult to treat. And we see that even though there's a delta at week 16 with 21% of patients reaching IgE 0/1 versus 11, it is lower than the other subgroup. So it's probably the subtype that responds less than others to topical delgocitinib. Irritant contact dermatitis, 55-25, good response. Allergic contact dermatitis as well. Vesicular hand eczema, 53% versus 5.6. This is the highest, the biggest delta. We're down to 69 patients, so this number of patients is a little lower, but the efficacy was good in vesicular hand eczema. So this is the same type of data, but for XE75. So it parallels what I just showed, so I won't go through every figure. However, when you look at the hyperkeratotic, it fares better. It's still the subgroup that didn't do as well as the others, but it's much closer. Now, this is probably, again, an issue of the IgA, because any sign of hyperkeratosis or any scales left meant that the patient was a non-responder. And if we're focusing on patients who have hyperkeratotic hand eczema, it's a little bit more difficult to respond. The other thing that I forgot to mention that I thought was very interesting was that if you look for hyperkeratotic eczema, 21% are responder at week 16, but if you wait up until week 52, you almost double the proportion of patients who achieve this response only once. And the percentage difference between week 16 and week 52, if you look at all the subtypes, is highest with chronic hand eczema that is hyperkeratotic. To me, what it means is that we need to be a little more patient with these patients. If they show some signs of response at week 16, it might be worth waiting a little bit more before concluding that we have not reached the efficacy we want. So systemic exposure, with delgocitinib, week 1, week 4, week 16. This is from the Delta 2 trial, fairly low in most patients. What you see here as a line is the concentration that you observed after oral administration of 1.5 milligram, which is not a huge dose. So what's interesting in the EMA product information, so I read it to make sure that there was nothing that stood out. There's nothing that stood out. The approval is for BID usage until IgA is clear or almost clear. So technically, we should tell patients to stop if they clear or if they're almost clear. In the events of recurrence, twice daily treatment of the affected area should be reinitiated as needed, and treatment should be stopped if no improvement is seen after 12 weeks. In the warning section, they talked about NMSC, mostly BCCs, which has been reported with topical JAK inhibitors. Periodic examination of application site is recommended. Topical ruxolitinib, so we heard a little bit about it. It's a JAK inhibitor. It's approved in Europe for vitiligo, in the US for atopic dermatitis and vitiligo. It's currently in phase 2 for chronic hand eczema, so we should eventually have data of a nicely powered trial in chronic hand eczema. In the public domain, there's this interesting trial, but it's a very, very, very small trial. So it's 15 patients with chronic hand eczema. Patients with allergic contact dermatitis were excluded if they could not avoid allergens. IgA from mild to severe. Ruxolitinib cream applied BID for 4 weeks. The mean XC at baseline was 55.7, so roughly in the range of what was seen in the delgocitinib phase 3 program. And the XC75 was 64%. So this is really good. However, only 15 patients and open label. So topical tapinarof and roflumilast, so these products are available in the US. Roflumilast is available in Canada for psoriasis. If they're used within label for atopic chronic hand eczema, this is the approved indication. No studies so far have been conducted with them in these indications. I'm convinced that series will come or investigator-initiated studies will come soon. What about systemic treatment? There's a JAK and SYK inhibitor that has gone through phase 2. This was published last year. It's called guzocitinib. The study was a randomized study where patients received either a placebo, 40 milligrams, or 80 milligrams. Primary endpoint was at week 16. In terms of severity, patients were a little more severe in terms of PGA, so 63% of patients had a PGA of severe, between 63 to 56, depending on the groups. The XC was 62 to 65. So these are the results. In terms of change from baseline in MTLSS, so those of you who are less familiar, this is an endpoint where you select the most affected side of the most affected hand and you evaluate its severity over time. At the time of primary endpoint, there was a statistically significant difference between the highest dose in red, the 40 milligram in blue, and the placebo in gray. In fact, the onset of action was very fast. You could see that it was highly statistically significant as early as week 2 after beginning of the administration. In terms of proportion of patients who achieve a PGA 0.1, in this study, the alitretinoin PGA was used, so it was not the one that was used for delgocitinib. Proportion was 30% for 80 milligram as compared to about 6% for placebo. In terms of adverse events, there were some adverse events that we've seen more frequently in patients treated with guzocitinib. Headaches, 16.9 as opposed to 3.1. Nausea, 12.3. Diarrhea, 6.2. Vomiting, 6.2 as compared to 0 for placebo. So dupilumab for non-atopic, I won't spend too much time on this because it has been presented and discussed. So this is an interesting, it's not a big study, but I like that study because it combined both atopics and non-atopics, and most patients were non-atopics. And as you have just seen, it showed that there was efficacy overall in patients. Dupilumab was superior to placebo, both from an XC perspective and a PGA perspective. I would like personally to see more studies conducted with dupilumabs and drug targeting either the IL-4 receptor or IL-13 in non-atopic patients with chronic hand eczema. So there's currently an investigator-initiated study in clinicaltrial.gov that is looking into that. No data yet to my knowledge. There's also an investigator-initiated study that was started a few months ago looking at abrocitinib in patients with moderate to severe CHC, atopic or non-atopic. And this one, I'm the sponsor investigator in that collaborative agreement with Pfizer, so randomization to 100, 200, or placebo. There's a lot of things that will eventually come up. There's an oral roflumilast study in clinicaltrial.gov, 40 patients, investigator-initiated study as well. Thank you very much. Any questions? Everybody wants to go home. I want to go home too. Very good. So thank you all. Thank you for those brave people who stayed until the end. And I wish you a safe trip back home. Thank you.